And if you guys have no objection, I want as well to put this online. Is that okay
Yeah.
with all of you? So it's
Yeah, okay.
be, to be live podcasted.
شكرا. That's perfect.
And I'm going to keep admitting whoever joins us.
شكرا. أنا أسكر الباب أحكي لحدا لما أخلص. Okay, thank you. تسلم إيديكي. شكرا.
So, Dr. Abdul Salam, I think floor is yours. So, Dr. Abdul Salam, I would ask everybody to mute yourself, and I'm going to do the same. Floor is yours.
Who's Dr. Abdul Salam? Is he the coordinator of? You are muted, Dr. Hamid. You are muted. You are muted. Muted.
Do you
Yeah.
hear me now?
Yeah, we hear you.
Oh, your video on the bottom left says maybe you're using somebody else's login. It says Dr. Abdul Salam, but
Oh no, my name is Ala. I thought there is somebody called Abdul Salam. So you want me to present now?
well, I think that is.
But it's wrong. It's Ala Azmi, actually.
Well, it says Dr. Allah Ahmed.
Yeah, that's right. This is my name. Not
Okay.
I thought you were talking with somebody called Abdul Salam. So do you want me to present now? Begin?
I think, let's see, it is Dr. Altier.
Yes.
Okay.
Okay.
Dr. Altier, you'll be the moderator. I'll be quiet.
Okay.
Please
Dr.
go.
Atir? Okay. So I'll share my screen. Do you see it?
You can.
Do you see it?
We are.
Okay.
Yes.
All right. Thank you for having me, and it's a pleasure to be part of the wonderful team that will talk about minimally invasive techniques in spine surgery. And since my name is Ala Azmi Ahmed, I'm a pediatric orthopedic surgeon. Because of that, I'll talk about scoliosis, whether it's adolescent or early onset scoliosis. I'm from Palestine and I'm based in Ramallah, and I'm also doing a lot of programs in Asia, Africa, and Latin America. So I'll begin. So though MIS is a technique that in adult and degenerative spine, it's well known now. I mean, most of the degenerative problems are done by minimal invasive. And so minimal invasive in pediatric is not quite popular as the degenerative, but it evolved significantly over the past decade. But what are the challenges for pediatric spine minimal invasive? Instrumentation of more levels. You know that, for example, in adolescent idiopathic, you can see very often that you go from T2 to L3 or L4, and this is very hard to do minimal invasive, difficulty inserting screw due to the rotation of the vertebra. And as you can know, so it's not quite going with the screw in the same fashion. You might have the concave side and you might tilt a lot. Limitation for the axis of the field, which makes fastectomy and fusion as a primary procedure more challenging, since most of our procedures is fusion. So you need to do fastectomy and you need to have appropriate fusion, increased radiation exposure from putting multiple levels of pedicular screws under fluoroscopy control. That would add significant risk to the children, and not only to the children, but also to the. Here in adolescent idiopathic scoliosis, how can we go with minimal invasive surgery? We have the Wilsey technique. A Wilsey technique is that you open usually, even if you open midline incision, but you go 1 to 2 centimeters lateral to it, and you go on the fascia and you open between, you open medial to the longissimus muscle. Actually, you see the longissimus muscle and you put your finger medial to it, and it will be between multifidus and longissimus, and then you go and insert your screw. This is some sort of less invasive technique that you don't do subperiosteal dissection, you don't cut a lot of soft tissue. It will give you access that will be also safe for you to put pedicular screws. And in pediatric orthopedic, we use that a lot, especially when we do early onset, which I'll talk to you about. So here are, for example, this is an adolescent idiopathic case, and you do less invasive. I don't think it's appropriate to say minimal invasive. It's more like less invasive technique that we put, as you can see, proximal incision, small incision, middle small incision, and distal incision. Usually it's about 5 to 6 centimeters each one. And it's much better to go, as I will see, so as you can have much better levels. If you go subperiosteal as usual, you'll need to open more and more. Hello?
Let me just check.
Is there a problem? Hello?
I think somebody didn't mute themselves. I muted them. Please continue.
Am I muted?
No, somebody, one of our participants
okay.
was
All
not
right.
muted. I muted them. Please continue.
All right. So, okay. So we go like here. For example, we put 2 screws proximal, 3 screws on the apex. Usually always go to the apex and put and 3 levels in the distal part. And even in between, you can have just 1 or 2 vertebrae maximally in between that are not joined with the pedicular screws, but you need to do fascicectomy, and you to do the fusion, the appropriate fusion levels in each one of them. So in technical details, what about technical details? Major curve, less than 70 degrees, and flexibility is more than 50% on the bendings. 3 small midline incision, usually 5 centimeters each. 2 to 3 levels are instrumented per incision. And also maximally 2 intervening segments between the instrumented vertebra. At each level, a stab wound is done 1 centimeter. So we go like what I told you, like Wilsey technique. It would be much easier to access more than 2 levels. Otherwise, if you do it the appropriate subperiosteal incision, you cannot go more than 1 level or 2 levels maximally. But with Wilsey, you can go with much more than 2 levels. Fascicectomy is done under direct vision, followed by pedicular screw insertion with the freehand technique. We must always remember that the main core of our surgery in children, in adolescent idiopathic, is fusion. So you don't compromise the fusion with any technique that you might have smaller incision or something like that. Angulating the table in a way that would get appropriate angle. Sometimes, especially when you go to the concave side, you feel some difficulty in putting the screws with these small incision. So you can tilt the table so as you can be more perpendicular to the axis of the spine, and it would be much easier to do it. And so rods are pre-contoured to correct the sagittal profile. The rods are placed from distal to proximal, going always under soft tissue, never going under skin, and the skin bridges to fit the screw tabs or seated within the tulips of the pedicular screw. All standards procedure for derotation, correction, using, sometimes you need to use some correction with in situ bending or compression, distraction. All of that can be done within the small incision. If you cannot feel that you can do it with the small incision, open your incision more. Don't compromise your correction or your fusion with the less invasive technique. Here we can see there is a girl. As you can see, she was decompensated with adolescent idiopathy. This is one of my patients in Palestine, and you can see the small incisions. You can see that the lumbar is a little bit bigger because the vertebrae are much bigger, so you need maybe to open more to have the 3 levels to be instrumented. And as you can see, here are the tubes that will make it much easier for you to go. And you can see the incisions, 3 small incisions that you can go through. Well, what are the advantages besides the cosmetic issue? Lower blood transfusion rate, shorter fusion, fewer pedicular screws, reduced hospital stay, and lower incidence of infection. Actually, I would put the lower blood transfusion and the lower incidence of infection. As long as you have smaller incisions that you can control, it would be much better and would decrease the infection. There is also the thing that is going on these days within the past 5 years. A lot is talked about is the anterior VPT. Anterior VPT is a non-fusion technique, but it's also for adolescent idiopathic scoliosis. And when you do the thoracic, you do it with the thoracoscope. And it's a limited, some sort of minimal invasive technique. And this is actually the first case that we have done in Palestine with anterior VPT. It's for a thoracic curve. As you can see, you need to check the anterior and the posterior part. But as you can see, we can go to the apex with less than 6 centimeters incision, which is around, usually we put it around 4 centimeter incision. And we go through, and you have one above and one below for the scope to be in, so as to guide you. And maybe there is a one for the chest tube. And we can see here, this is, as you can see, the distal one on the right side, on the left side, I'm sorry, the proximal one is the main incision. And here is one for the chest tube, and the one in between, in the left picture, I mean, is the one for the scope. And you can see the screws are put anteriorly, and you can see the chest tube, and you can see the bigger incision, which is about 4 to 5 centimeters on the apex, and the one in between the chest tube and the incision is the one for the scope. And here you can see, instead of having a big incision on the back, you can go with small incisions in between. So it's a cosmetic wound, fewer instrumented levels. It should have a learning curve. Actually, in the literature, they are saying that you can be competent after doing at least 11 cases. Small flexible curves, it must be 50% flexibility, otherwise it will not work. And you don't need to do the big curves. Pulmonary complication with this procedure include hemothorax, pneumothorax, and atelectasis. Of course, you are going through and you are cutting the pleura and you are going in. And complications related to instrumentation, of course, but it's minimal. Actually, the complications, maybe the vascular issue is the most important one. So what about minimal invasive technique in early onset scoliosis patient? It's not popular in early onset scoliosis, and you don't see a lot of publication. Up till now, I saw just a couple of publications about that. One of the publications, actually, it was published in the 3 years ago in the Clinical Orthopedic. Even in the comparison with adolescent idiopathic, and it's mainly due to the heterogeneity, difficulty of the cases, small pedicles, osteoporotic bones, severely deformed vertebrae and pedicles, and the need to go every 6 months for distraction. That is, if you are talking about the traditional growing rod, which is the most popular until now. Pulmonary insufficiency is also a major factor restricting anterior endoscopic approach in these patients, except for juvenile idiopathic cases. So here is a case that I did publish in a paper about myelomeningocele, and you can see the pathological skin here. And I did just a small incision above to put hooks, rib hooks. In she was a 4-year-old child with severe 90 degrees kyphosis. And I'll put hooks in a clawing fashion with a small incision above, and 2 incisions to put iliac screws down below, so we can avoid the pathological skin, and we can go with minimal incisions. Also, in the APC technique, that is active apex correction technique. It's a non-fusion technique that controls the apex through modulation, not through fusion, a kind of a procedure modification of the Sheila. And you can see 3 incisions, one for proximal screws, and this one that is exposed, it's for the tethering screws, and the distal one for the distal screws. So it's a kind of less invasive technique. And also we can put percutaneous pedicle screw fixation in this technique. Otherwise, it's very hard. If you want to put in multiple levels, it's very hard. But if you want to put these particular screws percutaneously in the tethering screws, it can be done. And the way of percutaneous screws is to be used with limited levels, good awareness of the deformity, and preoperative appropriate pedicle assessment. And for example, for the APC, when we did put the pedicular screws as a percutaneous, we only put screws on the convex side. So it's much more safer than putting it on the concave side. And this is the APC technique. On the left side, you can see the Sheila putting 6 screws in 3 levels to control the apex. Here in the APC, just the orange ones are one above and one below the most wedged vertebra in the convex side. So here are, for example, the screws, as you can see on the middle one and on the lateral and the AP view. You can see hooks above. Now we put also screws above, but we put tethered screws in between. And you can see that here. And here with this girl, she had more than 65 degrees cup angle. And you can see her much better after the APC. And you can see the small incisions for the pedicular screws above that were put percutaneously above and below the most wedged vertebra. So MIS is still relatively a new technique that makes it technically demanding, but an appropriate assessment of the vertebral body and pedicles preoperatively through, well, what we have a CT scan, increase the use of the 3D intraoperative radiation machine. Also, we have now the O-arm, we have a navigator, which might increase the use of the percutaneous screws and the minimal invasive techniques. So, but you don't need to begin with this kind of management. You need to go with the popular approach for scoliosis, and then followed by performing less invasive technique, such as 3 small incisions for AIS. Then you can go in another putting screws percutaneously, unless you are having a navigator, that would go much better. And go begin with small curves, beginning on the convex side, like in the APC technique. Don't go on the concave side because it's much harder and less safe. And the technique relies on good C-arm imaging, intensifier, and sliding the bed to overcome the difficulty of putting the screws without having the tubes or navigation. So it's not necessary that you have tubes or navigator, but if you have the rotation of the vertebra, you can adjust your C-arm so as to see how you can go, or you can adjust the table to make it much easier for you to go through it. Thank you very much.
Thank you so much. This was an amazing presentation. And there are so many questions, and I'm sure we will have some questions from the rest of the team. But my question, I have 3 questions that if you may elaborate on. Number one, you talked about how you choose where to put the screws. Do you mind a little elaborate more on that, on how you choose and how many screws to put where? Number one. Number two,
do you mean the adolescent or the early onset?
Yeah,
or both?
You see, that is, I think that's what I need you to elaborate. How do you choose in your patient population at what level how many screws to put in? This is the first question, but please go ahead with this, and then I have 2 more questions for you.
All right. So for the screws, for adolescent idiopathic, you regularly, as if you are doing just a regular adolescent idiopathic. For example, if the left shoulder is higher, you go from T2 and T3. If the right shoulder is higher, you go from T4. So you begin with the protocol that is usually done with adolescent idiopathic. But for sure, you need to control the apex. So you need to have 3 levels of the apex control because you need to rotate them, and the rotation will give you the appropriate correction because you are not putting the same density, screw density, like what you do in adolescent, just regular adolescent opening it. But you need also to have a space for doing fastectomy at each level. This is hugely important because unfortunately, sometimes we surgeons are distracted to new techniques and we forget the ABC of that we need to have a fusion, a posterior fusion and instrumentation. Now for the early onset and the APC technique, just putting the screws, you go proximal and distal, just doing subperiosteal because you need to fuse the upper and the lower part, but you need to have a non-fusion in the apex, but only on the convex side. So you always check with the C-arm. Check with the C-arm again and again to be sure that you are going with also the Wilsey technique. It's a must. You go 2 centimeters lateral and you put your finger medial to the multifidus, to the longissimus, I'm sorry. But the thing that I want to be sure about, that you have enough practice and enough knowledge to have the freehand technique. Don't jump to this technique until you are very fit in the freehand technique.
My second question is actually about how do you deal? I mean, that might be not a question for others, but I don't do pediatric scoliosis. How do you account for growth and for in this group of patients?
Well, this is my playground. Actually, now most of my work and nearly most of my 90% of my publications are about early onset scoliosis. And this goes with the growth. So we have some protocols in general. If you have a child who's having opened triradiate and he or she has a lot of growth to go, so you need to think about doing a non-fusion technique. Now, the non-fusion technique, you can go with the traditional growing rod, you can go with the magic rod, you can go with the APC technique. Everyone has its advantage and disadvantage. But in children that have a lot of growth to go, and the T1 to T12 is less than 18 centimeters, you need to figure out what to do to continue the growth, because the main concept of doing early onset scoliosis is to do a surgery that cannot be controlled by casting or by bracing first. When you do the surgery, to have the aim is to have a mobile, growing spine associated with growth of the lung. This is what we do. After the age of 10, or after you see some forms of that the child have went beyond the accelerated, the spurt of the growth, then you can go for fusion accordingly, according to the just the regular fusion techniques.
And it's fantastic. My last question is, obviously, I do consider it quite minimal invasive compared to what we know of pediatric scoliosis. What would you say the risk profile, infection, resurgery, this technique, your technique, versus the traditional midline incision, stripping the muscle of the bone? Do you have some data that you can, from your experience, you can share with us?
Well, from my experience, I don't claim that I have a huge experience in minimal invasive techniques, but I can say that the Koreans have published a lot of papers, and they have a lot of experience, and they are talking about a small 5-centimeter incision to do 5 levels. I mean, I cannot do 5 levels with 5 centimeters. I would do 3 levels. But in general, there is a change in the bleeding, the blood loss. It's true. But for the infection, I didn't find in my practice a difference in the infection rate. Knock on wood. I mean, I have very low infection rate, whether it's adolescent idiopathic. But the thing that we need to think about, it's not only the minimal invasive technique. It's also the nutritional status of the patient, if it's a neuromuscular case. I mean, there are a lot of issues that you need to have them as a package. So it's not like the minimal invasive. But the thing that I want every surgeon to think about, if you want to do the minimal invasive technique, you need to have a flexible, not a big curve, and you are very fit in doing that. Otherwise, don't bother to do it so as to be. Our aim is not to be the macho guys. Our aim is to have safe surgery for the patient. That's it.
Absolutely, absolutely. Now, thank you so much. This has been amazing. I put my email on the chat window. Please connect to me.
I would love to.
And,
Where is your email?
in
Okay.
the chat window, I put in the chat window my email.
Okay. Yeah.
I think I
Okay.
can say for all of us, the work you have been doing is very inspiring, and all of us really, I cannot
Yeah.
finish this without saying that our hearts all over
Oh,
the
thank
world
you.
is bleeding for you. Okay,
Thank you very much for your support. That's a big issue for me, actually. Thank you very much. And we are as doctors, we need to be the ones who would feel much more than anybody else about the situation here in Palestine. Thank you very much for your support.
Thank you. Thank you for being with us. I appreciate that. And please connect to me offline.
Yeah, I'll send an email tonight to you. Thank you very much.
Thank you. Bye-bye.
Have a good day.
Dr. Alkir, I know your connection might not be the best, but based on your final edition of that plan, Dr. Tara Hamasharif is the next. So I see Dr. Tara. Please, if you don't mind, without further ado, you take the platform.
Hello, everyone. I would like to ask for a permission to share my screen, if possible.
I think you will be able to do so.
Yeah. Can you see it now?
It says it's still sharing it. I'm sure it's just going to take a while and come up.
Okay. Please tell me whenever you see it so I can start presenting.
I think it is still working on that. Maybe you would like to. Okay, here it is. We see it now. Please go ahead.
Okay, good afternoon, everyone, and good time wherever you are. I'm really thrilled to be here among these distinguished spine surgeons. When I was first contacted to give a talk about in the conference about the minimal invasive techniques in spine, I thought I will talk something about endoscopy, but then I thought I'm sure there will be a lot of people who will talk about endoscopy. So today I will talk about exploration of the olive technique along with percutaneous screw, its role in minimal invasive spine. My name is Tara. I am a neurosurgery resident, 5th year of Arab Board for Health Specialization. I do my training and my practice in Erbil Center, Kurdistan part of Iraq. Before I start, I want to show my gratitude to one of my seniors that I'm learning currently spine surgeries, Dr. Wael Al-Qasim. He's teaching me about deformities, about minimal invasive and endoscopy. And the cases that I might be sharing will be Dr. Wael's case, and this is under his guidance. So what is olive? Before I go into the olive, I want the attendees and anyone who is here to ask themselves a simple question of knowing the difference between ACDF, anterior cervical approach versus posterior cervical approach. Which one of these is less painful? Not just less painful, which one of these is less destructive, is quicker, and has a less bleeding? I think the answer for anyone who works in spine will know the answer would be ACDF. If you look at these 4 radiographs, X-rays, lateral views of lumbar spines, and I would ask you the question, what do you see a difference between these 4 pictures, at the first glance, any one of you might think that obvious difference between these 4 pictures would be the degree of the listhesis. Well, that's not the only difference, but the difference is also the type of the spines that we see here with the sacral slope and the lumbar lordosis. Why do I talk about this? Because in the 2005, Pierre Rosoli made a groundbreaking study in publishing, dividing the humans or population spines under the study under the title of classification of the normal variation in the sagittal alignment of human lumbar spine and pelvis in the standing position, and divided the population spine into 4 subtypes by counting or depending on the sacral slope and the lumbar lordosis. Why is that important? Because after that, following many studies were published differentiating between the different types of spines and different types of the pathologies that will affect these patients. One of the studies was this one that was saying that degenerative diseases might be more common and in the patients or in the persons with a high pelvic incidence and high sacral slopes compared to the ones with more flat backs that are more prone to discogenic problems. So if I go to Olive, before of that, I want to mention what is MIS. MIS is not only about having a small skin incision, it is about less soft tissue damage, less bony work, less bleeding and shorter operative time, and less post-operative pain and shorter hospital stay, less risk of infection, of scarring and adhesion, and maintaining at least or improving the stability of spine, having all this while at the same time achieving the same goal that what was previously achieved by the open classical traditional surgeries. What are the indications of Olive? Degenerative disc diseases, spondylolisthesis, spinal stenosis, and redo operation. The patients with scar and adhesion might be a good candidates for Olive, since avoiding the adhesions in cases that needs lumbar interbody fusion. Olive is a good option to think about. Here, I would consider or I will focus my presentation more about spondylolisthesis, since this may need more indirect decompression and only sagittal correction. I will not go into the details of these studies due to the time limit, but overall, there are many studies published in many classifications of the spondylolisthesis, starting from Meyerdien's, Newsland and Newman's classification and Marchetti classification, but none of this was giving an insight about the prediction of the progression of the pathology or guiding the surgeons into the how to choose a future, how to choose our operative approach or our operative procedure until in 2005, SDHD Spine Deformity Study Group have made a classification of grading of the spondylolisthesis along with the spinopelvic parameters, and then CARDS have made its own classification, and there were studies that were showing comparison between CARDS and SDHD. It is important because here the simplest classification to understand is SDHG. Well, they classified the spondylolisthetic types into 6 subtypes, the 3 of them with low-grade listhesis, less than 50, and the grade 4, 5, and 6 into more than 50%. In the grade 5, where the patient is still preserving the sagittal balance and having this normal pelvic tilt, while the type 5 having a high pelvic tilt, however normal, but still preserving the sagittal balance, and in type 6, it has a disturbed sagittal balance. Why is that important? Why I'm mentioning along going through all of this? Because it is important for any surgeon when they encounter a patient with spinal pathologies to think and to measure the spinopelvic parameters in the spine of the patient, at least including sacral slope, pelvic incidence, pelvic tilt, lumbar lordosis, and C7 plane line, C7 plump line as a basic spinopelvic parameters to guide to a better approach. When it is about correction of the sagittal balance and maintaining or preserving or regaining the disc height, lumbar interbody fusion is the ultimate solution. This is a simple diagram of all the lifts, including P lift, T lift, L lifts, which is either D or X lift, O lift, and A lift. According to the GWAS, the goal of the surgical treatment of spondylolisthesis is the fusion of the smallest possible number of the mobile segments of the column, which restores the sagittal vertical axis. Also, not just sagittal, but coronal, along with the sacrum and lumbar column in as normal as possible position, and the fusion of the non-competent disc space. So what is OLIF? OLIF is, as I mentioned in the very beginning, is to give you a picture, a simplified picture. It's OLIF is a magnified form of the Smith-Robinson's anterior cervical approach. It's a minimal invasive approach to the lumbar disc through through a plane of devoid of muscles. This is an axial section of the lumbar spine. You can see the major vessels, aorta, inferior vena cava, the two psoas muscle, and here is the trajectory of OLIF approach, which is basically in between everything without having to cut or to deviate anything. Preoperative planning of OLIF would include the location, marking of the location of the iliac crest to know how far down you can go, and the location of the lower ribs, and position of the psoas and the kidneys through the radiographs, basically axial MRIs, to see the neurovascular structures, because sometimes you can see here aorta and vena cava are shown, but sometimes the vessels are well attached to the vertebra that in some cases minimal transposition is needed. I will talk about it later, which make it difficult. So very well preoperative studying of the structures is very important, along the oblique angle of the entry into the disc space and the curvature of the spine. So why OLIF? Why would I choose OLIF? To answer this question, I have to go through the techniques of OLIF step by step. First of all, the patient would be positioned in a lateral decupitous position, and left or right, it didn't really matter, but some studies showed that the left approach, the surgeons who did the left approach and compared to the right one, somehow the left was more comfortable and wider angle. The patient should make sure that he is in the true lateral by doing a fluoroscopy, AP, and lateral views to show that the pedicles will be in the same line, no deviation, and the end plates of the vertebrae are in the same line. So this will lead us to the next step, which is marking of the skin incision. Here is a diagram of how to mark each body and each disc of interest. The skin incision zone would be between 4 to 10 cms anterior to the anterior border of the vertebrae, according to the patient's body mass index. And this is all marking. This is a patient that we did, Dr. Wild did, and I was with him as a first assistant. So a few days ago, the patient was 108 kgs, around, that's I think equal to 240 pounds. And the marking of the vertebrae and interbody disc spaces. After skin incision and opening subcutaneous fat, you'll encounter 3 layers of muscles, abdominal muscles. This diagram is important because the direction of the fibers of the muscle is important, and any layer of the muscle, we just do splitting of the fibers without cutting any muscle. Of course, opening the fascia, then splitting the muscles. That way you will not distract any muscle. This is a trajectory or a schematic diagram of how the retractors will go and reach the vertebrae. This is our real-time intraoperative retractors. When you reach the vertebra, you'll count some vital structures such as segmental arteries, which we usually see over the lateral aspects of the vertebrae. However, it's easy to avoid, and we also see the sympathetic change and genitofemoral nerve, which will be lying over the psoas muscle, and it is retracted posteriorly, decreasing the risk of wrist injury. This is actually, I was seeing very well the segmental arteries and the sympathetic change, but probably my phone was not helping me to show it clearly here. However, this is an intraoperative view of how you see the disc space. 3 level of Olive was done through the same incision, which I just showed you in an obese patient of 4 cm only. After you do the interior fusion, when direct decompression is not needed and only the correction of balance is required, you can go for posterior fusion by percutaneous screw without opening any wounds. As a lot of people is familiar with this technique, 2 levels up to 3 levels percutaneous screws. This is a scarring of the post-op 2 weeks, and even up to 4 levels of percutaneous screws can be done. In case you wanted to avoid percutaneous screws, if not familiar with it, or you don't have navigation and want to avoid the amount of the radiation, trajectory screws would be a good option since it is an open wound, but there's a minimal distraction since the exposure would be only on the lamina. You don't have to expose the facets, or you don't have to go far lateral to expose the transverse processes. So trajectory screws would be a good substitute for percutaneous screws. Back to the question, why Olive? Because it's a very good MIS approach due to the reasons I just mentioned. As we look at this picture in the left-hand side, you see the grade 1 the spondylolisthesis between L4 and 5, and the foramen is well compressed and narrowed, and the body is pushing, giving somehow a look of nutcracker's spine. And on the right-hand side, 1 level Olive, restoring the height of the disc space and indirectly decompressing the foramen, having a very wide window. So why Olive? Because it achieves well achieves decompression. Direct end-plate preparation and bigger cage. Olive cage size is much bigger than compared to TILIF and PILIF cages. So it has a bigger contact with the end plate, as well as preparation of end plate is under direct vision. The surgeon can see very well the bones and to remove any extra disc material. So the result of this will be a better fusion. Here, again, so many other studies have been published telling us that in the SDSG classifications, the lower types 1, 2, 3 may need only a fusion without reduction or simple decompression with fusion. And in type 5, we might need a simple reduction with fusion. But when we have a type 6 of sagittal malalignment, we have to think about restoring the sagittal balance. And as I mentioned, restoring sagittal balance will be by restoring the lumbar lordosis and restoring the interbody disc spaces. And this will help us by having hyperlordotic discs. Here, you can see how we have returned the pelvic incidence and lumbar lordosis mismatch is regained, or it is treated. And here I mentioned about the hyperlordotic cases because the maximum lordosis that you can achieve through PILIF or TILIF is about 8 degrees. While in a hyperlordotic cages of Olive, you have many options that starts from 7, 12, 18, even up to 20 to 24 degrees, which is a very high lordotic that cannot be achieved through PILIF or TILIF. So another reason is better restoring of the sagittal balance. And lastly, it can be done through L1 to S1. Up to 3 disc spaces in 1 4 cm incision is done by only sliding the retractor. In a very obese patient doing L2, 3, L3, 4, and L4, 5 disc through the same 4 cm incision, and only by sliding the retractor without a requirement of increasing the incision or without requiring doing a next incision. So multi-level, less distraction, less complication. Even even when a L5S1 is needed, which is it's considered to be very difficult in olive, but we have a solution for that. There is a solution for that, which is oblique leaf, that is an incision a little bit anterior to the classical olive incision, and the trajectory will be the same through the same plane of the devoid of muscle, same retroperitoneal approach, but just like A-leaf will be between the bifurcation of the main common iliac arteries, here you can easily reach the L5S1. So if you wanted to even go further down to L5S1 with a smaller incision anterior to that, or even some surgeons would do the same incision, but the muscle splitting will be a little bit anterior to the classical one and easily reaching the L5S1. So while I'm mentioning all of this, some of you might ask then if these are achieved all through olive, then might be achieved through other lateral or anterior approaches. What would be the benefit of olive? Its ability to access multi-level from one incision, as I've explained it now, even the ability to access the L5S1 through oblique olive, or it's called olive 5-1. It is ability to access the upper lumbar levels, which is might be very difficult or impossible or very risky due to the transposition of the great vessels. A-leaf is not able to do L1, L2, or L2 or L3. Ability to directly visualize the anterior longitudinal ligament and release of the anterior compartment when it is needed for the correction of the sagittal balance. Its approach is anterior to the psoas muscle. Unlike the X-leaf or D-leaf and other L-leafs, you do not have to go through the psoas muscle. No need for neuromonitoring itself is another benefit, but imagine going through lateral, through X-leaf, through psoas muscle with no muscle relaxant, and the patients under neuromonitoring. There is no need, it is also minimal mobilization for the blood vessels unless ACR, anterior column release, is needed. Otherwise, there is no need for vessels transposition. However, if needed, there is a minimal transposition of the vessels can show us the ALL, and of course, decreasing musculature and neurological risk due to all the above reasons that I have mentioned. One of the concerns of patients going into lateral, under lateral approaches is a neuropraxia or post-op due to the bed breaking. There was a study done comparing the other anterior lateral approaches to the olive. The risk of neuropraxia post-op in olive was minimized because there was no need to break the bed as it is needed in cases of X-leaf and L-leaf. Talking about all of these, of course, olive is not devoid of complication. It contains other, like any other operation, it has other general operative and post-operative risks of complication, anesthesia complication, vascular injury, which I mentioned should be very minimal. However, iliolumbar vessel, apart from segmental vessel, iliolumbar artery would go over the lateral surface of the L5, so that when the surgeon holds a retractor, should be aware not to put a pin over the retractor on the lateral surface of L5, as this may damage the iliolumbar, and upon removing the artery, may encounter a huge amount of bleeding. And neurological injuries is also possible, as I mentioned. Genitofemoral nerve would be over the psoas muscle, but it's very minimal risk, and sympathetic chain will be anterior to the vertebrae. Dural tear is also possible, but it's very rare. Kidney and ureters in the preoperative study and imaging of the kidneys and place of the kidney should keep us safe from injuring it, and the ureters will be going with the peritoneum to the anterior, also very minimal risk. Ileus, however, and risk of subsidence in the studies compared to the other anterolateral was more in olive than in the other anterolaterals, but the other complications were either equal or less. Well, after mentioning all this, this leads us to a conclusion that time is a very important factor in all surgeries. Under skillful hands, 3-level of olive, as I mentioned in our patients, and 4-level percutaneous screws in under 2.5 hours with less than 100 cc blood loss in a 108 kg, which is equal to 240 pounds. Patients for the restoration of the sagittal and the coronal balance and correction of the corrections and the indirect decompression with changing 2 positions is, I think, an amazing advancement in spine surgery so far, and we are still yet aiming for more in the future, hopefully. Thank you for your attendance and for listening. That's all.
Well, thank you very much. That was a great presentation. And certainly OLIF, ATP, as we call it here, is a very powerful tool. I think everybody who is in a spine surgeon should have that in their repertoire. Obviously, the oblique approaches are in 2 categories. Anterior oblique approach, what you describe, OLIF, anterior to psoas, ATP, or oblique transcambine OLIF that we will give a presentation pretty shortly. And generally, the OLIF ATP is OLIF-ATP, and so that we just don't confuse them. And transcambine OLIF is oblique lateral posterior lumbar interbody fusion, OLLIF. But when we are talking about that, we are referring to it through transcambine OLIF to just distinguish that. I have actually one question, and I'm sure Mohammed will have maybe some other question. You referred that you can do multiple level from L1 to S1. Is that correct? That this is suitable for surgery from L1 to S1?
Well, yes, it is possible. As I mentioned, we have already done L2 through L5 through the same incision. L1 and L2 is also possible. What is difficult in OLIF is L5 S1. And I've mentioned that for L5 S1, just another anterior incision, or even through the same skin incision that extended anteriorly and through the same oblique window, but the muscle splitting will be a little bit more anterior. And instead of being lateral to the iliac, left iliac artery and left iliac vein, we would go into the between, just like an ALIF between the 2 branches of left and right common iliac vessels. So it is possible multi-levels. Yes, it is possible. L1 through L5 through the same 4 cm incision, and L5 S1 maybe just extending the incision a little bit more.
So is my assumption correct that the optimum levels for OLIF ATP is L2 to L5, and with modification L5S1 and L1, L2 are suitable, but they are inherently different kind of procedure. You have other consideration there. Is that assumption correct?
Yes, it's correct.
Now, one last question. When you do your instrumentation with screws, do you use navigation and put them in lateral, or do you reposition the patient and do it traditional percutaneous screws?
Well, this depends on the center and the place that we work on. In some places, we do have navigation that it's possible to keep the patient in the lateral position. However, the surgeons will not be very comfortable with that.
Yeah.
But usually, the centers where I work with Dr. Wa'i, we have to reposition the patient. So timing that I've mentioned, 2 hours and a half, with including changing of the position also. So you can imagine 2 hours and a half for a obese patient for 3-level, 4-level fixation is, I think it's amazing.
Well, thank you very much. This has been an amazing presentation. So I think according to the plan, the next speaker is my good friend, Dr. Mohammed Albar. And he's quite famous and very prolific. And I have been stalking him online. I see what he's doing. And he has not had a chance to come and visit me. So I want to offer you, Mohammed, please be my guest. Come here, visit me. I think you and we have a lot in common, but I'm going to just learn from you right now. So please go ahead.
Thank you so much, Dr. Hamid, and it would be my pleasure to come visit you. So far, the talks have been amazing. I've learned a lot already. So today I'm going to be talking about spine care for the future, the role of artificial intelligence and robotics. Here are my disclosures. So if we look at the background, low back pain is a major problem. It's the leading cause of years lived with disability. The impact is about 50 to $100 billion per year, and it's the largest direct healthcare cost in the United States. If we look at currently, when a patient has low back pain, it's almost like a zoo. Depending on where they go first, then we'll kind of pretend where they're going to go next. And this really shouldn't be the case with any medical problem. So the question that we wanted to ask was, can we use machine learning to diagnose, triage patients with low back pain? So this was actually a cover article at the Spine Journal in January. And what we did is we looked at some studies. We had about 200 studies at the end of our looking. And we split up the care of the patient into four main categories. We looked at risk prediction, then we had detection, then we had management, and then we had outcome prediction. And not surprisingly, we found that there's an explosion of interest. So if you look at in the years and how many publications about this, it's been a lot. Most of them are working on detection or outcome prediction. If we look at the type of machine learning that's been used, most of it is neural networks. MRI is a key part of this, but other people are starting to look at more other things other than MRI. If we looked at the bad part, we found that only code validation or external validation was only very minorly talked about. And if we looked at what people were looking at, a lot of them, again, was looking at image abnormalities. Could we use machine learning to figure out if there's an imaging more abnormality, whether there's low back pain presence? Kind of on a bad sense, we know a lot of patients with back pain will get better just with physical therapy, and only one article looked at whether a patient will need physical therapy. We also looked at this with other collaborators looking at spine deformity. And again, most of it was on the diagnosis and classification. So if we look at my working here at Duke, what is the Duke experience? We see that only 20 to 40% of patients that come to like a surgeon like me end up with surgery. And there are also a certain amount of patients that go to the non-operative practitioners, such as the chiropractors or the physiatrists, that should go to the surgeon. So this causes frustration both on the patient side and on the practitioner side, right? So when I see 60% of my patients don't end up needing surgery, that causes frustration on the patient side as well as on my side. So we were trying to implement a machine learning, a predictive model that will hopefully triage patients to the most appropriate practitioner. So first of all, we looked at algorithm training. And one of the things that we really struggled with is should we consider success? If we consider patient-reported outcomes only, that could be limited, right? Because if Mrs. Jones comes to my office and she has a grade 2 spondylolisthesis, and I just give her 100 milligrams of morphine every day, her patient-reported outcome might be very high. She might say, Dr. Abdulbar is a great doctor, but that's not the best thing for this patient. So what we try to look at is healthcare utilization. So first of all, we want to see, can we predict which patients will decrease or stop using opioids? And so far, using our models, we're moderately successful in figuring out who will be opioid free at 90 days or 100 days or 365 days. Another thing that we wanted to look at was ED visits. So if I do a 2-level spondylolisthesis correction, but Mrs. Jones comes to the ER every two weeks, that's not good. And actually, we were actually very good at predicting who would not need or who would come to the ER at those time points. And so currently, we're trying to move from this zoo to a more systematic workflow. And we're working on this, and hopefully next year I can give you better results on how we've been successful in changing that workflow. And now I'm going to change gears a little bit and talk about some other things. So, as Dr. Tara talked about, when the appropriate patient comes to my office, it's sometimes very confusing. Which surgery should I do? Every day now, there's a new letter added to the if, Z lift, A lift, W lift, almost every letter now is being used. And how do we decide which surgeries to do? Um, and should it be based on surgeon preference? Or should it be, I think, should be done on patient specific and pathology specific? If you look at the current planning software, they only look at bony structures and looking at uh, spinal pelvic parameters and so on. But we know that nerves, vasculature, muscles, ligaments, as Dr. Tara showed, you have to look at all of these things when you're trying to do this. So what we've done is actually we've worked very hard to do this manual segmentation of all aspects of the spine. So we're looking at the psoas, we're looking at the bones, we're looking at the nerves, and from that we are deciding which pathway we should do. So for posterior fusions, should we use, Dr. Hamid's transcambin? Should we use also the transfacet that he's talked about? Now we not just had it on, surgeon preference, but now we actually have morphological markers to decide. And I won't get into this now, but we've actually done a new, what we call TLIF algorithm. If you're interested, actually, I think on Wednesday, I'm giving an AO seminar talking about this TLIF way and algorithm. So stay tuned to that if you have time. Now we'll switch gears a little bit and talk about robotics. A lot to cover today. So if we look at robotics, robots should be kind of human-like, but right now we basically have what are called cobots, which is a computer-controlled robotic device designed to help a person. And our current manifestation of the spine robot basically is just a expensive drill guide. And so right now, the FDA in America has only approved robots to help determine the screws, and you still might have to place the screws yourself. And there seems to be sometimes this argument, is it man versus machine? This is Gary Kasparov in 1997. Just to show you how old I am, I asked my resident who Gary Kasparov is, and nobody had any idea. So, but when I was growing up, this was, very big in our thinking, right? That we were going to have to fight these machines. You can see here, he has his hands on his chin, and he was feeling like the whole weight of humanity was on him. But now he wrote a book, 20 years later, when he says, we need to embrace the machines. We need to see what their limitations are and what our limitations are and work together. And so I think that we need to use intelligent machines to help put our grandest dreams into reality. So looking at advanced applications rather than just screw placement, we've used actually the robot to enter into Camden's triangle. And so Dr. Hamid will talk a lot more about Camden's triangle or Camden's prism, but we've actually used it to target Camden's triangle in certain cases. This is a 64-year-old gentleman who had a grade 2 spondylolisthesis, L5S1. He refused general anesthesia, so we couldn't do a O-lift or a A-lift. So we did a T-lift on him. So we put the screws percutaneously, and then we used the planning software actually to enter into Camden's triangle percutaneously. So we did this under spinal anesthesia. We bored this from our awake craniotomy colleagues. Here we are, we put the screws, and here we are getting into Camden's triangle using the robot. You can see here this was done with minimal blood loss, and then patient can go home the same day. We wrote up the case report, and now we have a case series actually of these patients. You can see here we are measuring Camden's triangle. The blood loss is less than 100 cc's, and many of these patients go home the same day. Other applications for iliac fixation for either tumors or unstable fractures. So here's a 48-year-old with a very invasive colorectal cancer. This is a non-operable lesion. However, he also has a sacral insufficiency fracture here and had a lot of right-sided hip pain. So what do you do to this patient? If you do a traditional lumbopelvic fixation, that's going to be an open case. He's going to stay in the hospital for a long time. He only has 6 months to live. That's not appropriate for this patient. However, if we can do this completely percutaneously, that might help this patient. So one of the big advantages of the robot is that you can plan the screws so that the screw heads under the skin all line up in one. And so you don't have to make a mini open incision. You don't have to have a connector. And so you can do this surgery. Here we have the Wiltse approach for the screws, like Dr. Alat talked about. And then, this is interesting. So this incision here is for the screws on this side. And so it's kind of mind-boggling. But all that matters is what happens underneath the skin. So you can see here, we still use x-rays after we put in the screws to make sure everything is good. You can do here, this was our first case. We had 150 cc blood loss. He was able to go home the next day. His pain was better. He ended up, unfortunately, dying after 6 months. But we actually gave him good quality of life during his time that he was alive. How about unstable sacral fractures? We see these in high velocity trauma, or now we see a lot of elderly people with insufficiency fractures. So here we have a patient who had a large MVC. You can see here very comminuted sacral fracture. What are you going to do with this patient? She has a DVT. You don't want to do open case because you want to put her on blood thinners. So on. So we can do this surgery again completely percutaneously. We can avoid the other fixations that the trauma surgeons have put on here. We can do this now, completely percutaneously. We've gotten better now with only 25 cc blood loss, percutaneous again, and we can do really well with these patients. We've published about our case series of using this percutaneous way to do iliac fixation. How about the transfacet TLIF? So as we started studying Camden's triangle, we know some people's Camden's triangle was less than 6 millimeters. That's too small. So using this segmentation software, we're able to look at the different corridors. We found that the transfacet corridor in general is larger. So here's a case, grade 2 spondylolisthesis, not very good candidate for either direct lateral or OLIF, right? No real corridor for here. So what we did is we used our preoperative software. We make a trajectory to avoid the traversing and exiting nerve route. We put in the screws using software that we've looked at to decrease the radiation. And then it's my standard operating procedure after putting screws to get a CT scan to make sure all the screws are good. So we got a CT scan, and then we merge it with the preoperative MRI, and then we can look at our trajectory. And now we're overlaying the MRI to the operative field. Kind of like Iron Man, but now we're Spine Man. So under the microscope, we can actually now, as we're doing the transfacet TLIF under the microscope, we know through the bone where the L5 nerve root is and where the L4 nerve root is, so we don't cause injury to the nerve roots while we're doing the surgery. We've started to look at using the robot to dock in the perfect trajectory to do these transfacet TLIFs, and hopefully I'll be able to present on that in the future. Right now, a lot of this segmentation is done manually by amazing medical students, but we're working on using machine learning to do this completely automated. So stay tuned in the future. So my brother is actually a pediatric urologist, and he uses the robot, but a different type of robot. And so I started to think about, can we use the Da Vinci robot also for surgery? So here's a patient, he's got a degenerative disc here at L5S1. We started to look, he doesn't have a spondylolisthesis. So some people say, well, do you even need to treat this? So we've actually started to use CT SPECT to look at whether we think that this is a pain generator. And this is work that was done by a medical student and now is a resident here. So she did this work, which was just recently published, looking at 3 different signatures of CT SPECT, whether it's around the disc space, whether it's around the facet joint and the disc space, or whether it's around the facet joint alone. And she showed that very remarkable results that it seems that those people that only had the facet joint pain did not get better. So for this patient, we decided to do a L5 less an ALIF. with possible decompression as a stage 2 because I was just worried that we weren't going to get enough indirect decompression. Usually this is done with an access surgeon, but we know that, when we do kind of A-lifts, we can have complications. So there are different minimally invasive options, such as laparoscopic or Da Vinci. We published this paper on a systematic review of those techniques. We found that laparoscopic A-lift, they were operative time were a little bit longer, but there was definitely a learning curve. And how about robotic A-lift? Only a few case reports have been published. And so basically what we're able to do is the surgeon is sitting over here with these end effectors at the patient, and then they're able to get us access to L5-S1, completely laparoscopic. For the neurosurgeons, this is using ICG to make sure that we're clear of the iliac vessels. Here we are making sure that we're at L5-S1. Then they actually open up one of the small ports and give us this direct entrance into the L5-S1. And then here we are doing the L5-S1 A-lift. Here are the iliac vessels. And now we're not looking straight into the patient. We're looking actually through the robotic camera. Here's us putting our expandable cage. This is a trial. And then here's the cage. And so, this is our very first case, so it took us 4 hours. We've done more since then, and we're getting better. And so now this is, laparoscopic ALF with the robotic assistance. And you can see here we got very good post-operative imaging. And then we put the screws in using the robot posteriorly. We didn't have to do indirect decompression because his radiculopathy had gone better. And you can see here now it's just a very small incision for that ALIF. I think this is just the beginning. Hopefully in the next few months, we'll start doing multi-level ALIFs as well as robotic disc replacements. And I think the real future is in robotic spine tumor resections. So just to conclude, to be mindful of people's time, I think machine learning has promise in all aspects of low back pain, diagnosis, triage, as well as surgical planning. I think robotic spine surgery is here to stay. I think it's really important to figure out, which surgeries should be done with a robot and which surgeries we should depend on ourselves. I still use, fluoroscopy and/or navigation at times, and it's figuring out which cases are best suited. That's really important. And I think it's really an exciting time to be involved with patients with low back pain. And with that, I'll conclude.
Amazing presentation, Mohammed. And as always I expect from you, always in the forefront, 5 steps ahead of everybody else. So congratulations. This is truly amazing. Now, I think that's another thing that you and I have in common, the AI, use of AI in many aspects of medicine. And just so you know, that's another thing I think I would like to talk to you maybe offline about that. How can we implement AI without being, like any other technology, robotic, navigation, AI, that it's complementary, not a replacement for our skill. Otherwise, Mr. Spineman, you're going to make us all jobless. So you're going to replace all of us. But I think you're on the right path. The understanding that medicine is big data and human mind is not good for big data. We are very intelligent, but our capacity to understand big data is very limited. Combining artificial intelligence with the surgeon intelligence is a big deal. I like as well what you said about that it's a beginning. I know that it took you 4 hours, but the first flight was shorter than the jumbo jet, length of a jumbo jet. So you're on the right path. I just like to as well add that obviously you and I, we both believe in indirect decompression because that's the kind of surgery you just showed us. I like to, at least propose for societies to rephrase it as a physiologic decompression, rather indirect decompression. Because right now, Mohammed, you don't have radiculopathy. The reason you don't have radiculopathy is because your disc is maintained. It's not like your body is cutting your lamina or resecting your facet or ligamentum flavum. It is the maintenance of the disc base that enable you not to have radiculopathy. And that's what you do. You restore anatomy and physiologically decompress. And I think this rebranding is of what your work and my work is long due. Now, having said that, for everybody who's interested, obviously what Muhammad does is way beyond me. But on my side, in what we do in the ATU, we concentrate on the immediate use of AI. Literally, we are creating AI that literally reads MRIs for you. We have it. It does it. It does a very good job. We have AI that literally listen to you and your patient and make the medical record for you. And that is nothing new, but we have been using it now for 4 years. And we have like 10,000 reports on that, and it has really refined. And as well, I think the next step is the big data comes with adequate data gathering. That's another thing that we are not good at. I think involving in AI that the data is collected when it's produced is the next thing what we are working on. Like literally everybody when we see the patient, when we examine the patient, when we do the surgery, there are lots of data produced there. AI could be truly like your assistant, and while you're talking to the patient, get all those information directly. And that bottleneck is that the data, when you see your patient, Mohammed, and you gather the data to make it to a database that is later usable. I think we are working on that right now. Literally, like a Star Trek, you use the Iron Man, I use the Star Trek computer. This is what I need. And it listens to us and gathers the data. So, but I'm always amazed following you online, Mohammed. Great job. And let's absolutely connect offline. Dr. Altier, it is you. I made you host, so please go ahead and introduce our next speaker. Thank you.
Okay.
Hello, everybody. Is it? Sorry, my computer just crashed. Is it my time yet?
Yes, Dr. Kashtan.
Okay, perfect. All right, sorry about that. So I'm going to share my screen here shortly. Okay. Okay, can you see the PowerPoint right now?
Yes.
Okay, perfect. All right. Is it the correct view and everything?
Yeah, everything's perfect.
Okay. All right. So, all right. Let me see if I can. Is this better right now?
Yeah, this
Can you
looks
see it right now?
Yes.
Okay, that's better. All right, perfect. All right. Well, sorry again. I'm having technical difficulties. I've been away from home for a while, so I'm sorry. I was able to put this presentation together, but there's some of the videos that we'll try to pull up, but it might not work. But this is such an honor to be invited. Thank you very much. So my name is Osama Qashlan. I'm of Syrian origin. I am in practice in the U.S. I'm just joining the faculty at the Cleveland Clinic. I was a New York Presbyterian prior to that, so very, very honored to be here with you all, and great talks before me. So learned a lot for sure. I have conflicts of interest here. I'm going to be talking about endoscopy and specifically thoracic endoscopy for thoracic discs. And I do teach for Joymax and for Arthrex and for Globus here. So we talked a lot about Cambin's triangle. Cambin's triangle is the landmark that we have for spine endoscopy. It's super important. And the first question that people always ask is, why should I learn endoscopy? I'm already doing surgeries, doing a good job, having good outcomes, and why incorporate endoscopy into someone's practice? And the main reasons why people say, like, why am I going to do this are these four here. So it's a steep learning curve. you're treating conditions that already have overall good outcomes, you're not going to be as slick, you're not going to be as fast initially. And then there's an equipment expense, obviously. So there's a lot of roadblocks for a surgeon to say, you know what, let me pick this up. And my response to this is really to treat thoracic discs. So if you look at this, these are the benefits of endoscopy here. I know I only have 20 minutes to give a talk with the questions, so I'm not going to go through every one of these, but really the number one reason why, in my opinion, spine surgeons, or at least spine surgery groups, it doesn't have to be where everybody does endoscopy, but it has to be someone in your group, someone in your community that does these, because the treatment of thoracic discs, it's a game changer to do this. And I'm sure many of you all have already seen this. So really, out of the benefits of endoscopy, the number one benefit is treating thoracic disc herniations. And that's really what I'm going to focus on today. I'm first going to go over some examples and kind of my learning curve in terms of increasing the levels of complexity in terms of taking care of thoracic discs. And then after that, going to talk about navigation a little bit. And that's a project that me and actually Dr. Abdelbar are working on together, is trying to see if navigation could be very helpful in patients undergoing endoscopy, and specifically transforaminal endoscopic procedures. And then the last thing is just to go over what evidence we have right now in the literature that shows the benefits of thoracic disc herniations. And you know, I honestly could go as far as to say, as I think it's probably it will be standard of care to at least evaluate every thoracic disc herniation for endoscopy before we go through with bigger fusion procedures or transthoracic retropleural, whatever procedure is in your toolbox to treat these herniations now. So I'm really going to focus on first the technical part of this, my learning curve through this, and then talk about navigation, talk about evidence in the literature, and then kind of wrap this up. So hopefully it'll be a quick review of all this for many of you, but hopefully a lot of you can learn something from this as well. So what's the first case that I treated with this? So this was a patient who presented with chronic myelopathy symptoms, was worked up by neurology, was worked up by physical medicine and rehab, was worked up for any potential cause for these myelopathy symptoms, problems with walking mostly. And at the end of the day, after talking to all the rest of the specialists, they said, this disc herniation is very small, but I think this is the cause of this patient's symptoms. And that's when they ended up presenting to me after, exhausting all other measures with all other physicians. And as you could see here, there's a thoracic disc herniation, very central, but very small, localized to the level of the disc space at that level. And you could say maybe it's a little bit more on the left side. So for a lesion like this, traditionally you would do either a transthoracic discectomy, or you could do a transpedicular approach with a plus minus fusion. All these procedures are open procedures. Could you do this with a tube? Yes, but it's very, it's just hard because you're trying to get around the cord. And as we all know, the thoracic cord, especially when it's already injured or already stretched because of the lesion, is very, very susceptible to injury. So endoscopy is a game changer in situations like this because you're able to kind of push the envelope and take on cases that maybe you're not sure, is this the cause of the symptoms or not? Because the morbidity is so much less for the patient. So for a patient like this, I offered a left-sided transforaminal microdiscectomy. Went in on the left side because, as you could see here, it's a little bit more on the left side. You could go to it from the right side too, but for me, I thought it was a little bit more on the left side. That's why we proceeded with that option. So that's what we did. So a left-sided transforaminal T8-9 microdiscectomy. For all these patients, if the disc is not calcified, if it's something that I'm not confident I'm going to be able to count correctly in surgery, I always mark these patients pre-op. So for all these thoracic discs, if I can't see it on an intraoperative CT, I usually send them to radiology, or I do it myself. I do a kyphoplasty around where I think the incision or the lesion is. And then I do an MRI afterwards. That way, intra-op, I only have to count from the cement to the level of the disc, which to me minimizes the chances of doing a wrong level surgery, which is, again, very, very, I think, very possible when you're doing endoscopy because you're not really seeing everything. You're like a sniper. You're really looking at one certain area, and sometimes you're in there and you're not sure, is this a disc herniation? Is it not? So it's important to be very confident because it takes that stressor out of the way. And this over here is the approach. So you could use a spinal needle, you could use a Jamshidi needle. The Jamshidi needle is easier because you're able to go through the rib head a lot faster. And the distance off the midline that you take, you can measure it off the preoperative MRI, or you're able to kind of feel the hump of someone's ribs. Once you feel where that hump is, that's as far lateral as you can go, because you don't want to, if you go past where the hump is, then you're going to go through the rib cage to get to your lesion, and you don't want to give someone a pneumothorax. You start very, very shallow, and as you get close to where your lesion is, you start, raising your hand up. And what you're aiming for is to get to this. This is like the perfect X-ray to where you want to start. On a perfect AP, you want to be at the mid-pedicle line, because you know that the spinal cord is going to be more medial to that. At that same point, on the lateral, you want to be right at where the PLL is. So in this situation, very safe. All the neural structures are far away from you, and this is a great starting point for starting or for doing this procedure. So you get the Jamshidi needle in there, you get your K-wire in there, you get your dilators and your reamers in there, and I'll show that a little bit more later. And then you get your working channel in there. So by this point, you've reamed a lot of the bone out of your way. You're in there, and as you can see here, you have a great approach to the disc space there. So, and as you can see, this is kind of at the end of the case. After you're done, you're able to go very lateral if you need to. That's what the first picture shows. The second picture shows the the instrument that I had past the midline there. On the third one here, you could see how inferior you could go, and then the fourth one, you could see how superior you could go. And this is the postoperative CT. So the postoperative CT really shows a very minimal area of bony destruction. And you could see that angle, it's perfect. And especially these scopes are 30 degrees, so you're able to really look right at the lesion and able to get that off. So, and this is a postoperative MRI showing complete, that the lesion is gone. Before my computer crashed, I had a video here. Let me see if I can get out of here and pull it up on my Instagram page. So let's see. Hopefully it doesn't. Can you see this or no?
Yes.
Okay, so you can see the video?
Yes.
Okay, perfect. All right, so as you can see here, so this is a fast video going through this. So I'm going to kind of go back to the beginning. And again, I apologize because the computer crashed. I wasn't able to. So here, this is the spinal cord that you see, and the instrument is going underneath it to kind of get the small disc herniation. This is a right-sided approach. This is a different patient from the one that you saw earlier. So this is the bipolar here. So you see the disc herniation right there. You're kind of finding a plane between the disc herniation and the spinal cord, or the dura of the spinal cord. And then you just go until you're able to flatten the area completely. So you can see here, you're just dissecting everything out and grabbing it, dissecting everything out, grabbing it. I do this obviously with neuromonitoring. Some people do this awake. But really, it's a very great surgery, very, very precise. And at the end, you can explore it, make sure everything is decompressed, and you get a great decompression with very little morbidity. 7mm incision, patients go home the same day or the next day. So it's really a great option to offer to patients. Okay, so are you, can you see the PowerPoint again now?
Yes.
Okay, perfect. All right. So as you can see, that's the first case that you do with this. It's nice to have a soft disc like the one that you saw. It's nice for it to be a small one. If it's a small soft disc, I think that's a great, great starter case in these types of surgeries. And then you can really start increasing the complexity of the case. So this is the kind of, once I get comfortable with the small soft discs, you could go to the next stage, which are big soft discs. So as you can see here, this is a patient that had similar symptoms, but much more acute. And as you can see here on the sagittal or the axial MRI pre-op, you can see this looks like it's a spinal cord. It's actually a humongous disc herniation, more on the left side than on the right side, and completely smashing the spinal cord. The spinal cord is completely smashed all the way over on the right side of the canal. And this is a situation where you go on the left side, you do the same thing that you saw in the last MRI, but you obviously get a lot more disc out to be able to decompress the spinal cord. And you can see here a postoperative MRI demonstrating that that disc herniation is completely gone. And you could see, again, another thing, you could see that black dot on the MRI. So this is another patient that I marked, because when I got a CT on this patient, it's not a calcified disc. I couldn't really count where I was. So in those situations, I always get cement augmentation of whatever vertebra, MRI afterwards, and then you get this. I know you could see it as being wasteful, but to me, it's less, I'd much rather be 100% confident I'm not doing surgery at the wrong level, especially when you're doing a risky case like a thoracic disc herniation. So this is what we did here. This is a post-op CT showing that other than removing part of the facet and the pedicle and the rib on the left side, everything else is untouched, which is great. And that patient did very well, went home the next day, went back to her life. So after you do that, then you do kind of, this is like the hardest. Now you're at the boss level. You know, you're at the last final level of whatever video game you're playing. And this is where you get the calcified disc. So this is someone who came in with more chronic myelopathy symptoms, got to a point that he really couldn't walk, and had weakness on that right leg. And you can see here, huge disc herniation, super calcified. And this is someone that before I learned endoscopy, I would offer a thoracotomy for, or maybe a retropleural approach to get great exposure of this and not have to manipulate the cord much at all. Obviously, we know those cases are very, very, have a high morbidity, especially in a case like this. You know that there's probably a CSF or there's a durotomy there somewhere caused by this calcified disc. So endoscopy really is a great situation or a great thing to offer for these patients. And for all these patients, I tell them, I'm going to try to do the endoscope. It might not work. If it doesn't work, you didn't burn any bridges as long as you didn't injure the patient. You can always go back and do the thoracotomy. You can always go back and do the transpedicular approach. So really for me, I tell them worst case scenario, I just loosen this up a little bit for the big surgery. Best case scenario, I get it all out and you're done. And this one here, we did a right-sided approach because the disc is more towards the right. So I have a little bit of a video here. So after lots of drilling of the joint, this was way more drilling than anything. You also have to drill, kind of core out the calcified disc. This is after coring out the calcified disc. And this is mainly to show kind of the rim of the, so this is coming in from the right side. So I'm finding the plane between the rim of the calcified disc and the dura, which is above there. And this is kind of cracking it down. And you're doing this under, you're using neuromonitoring, super stressful, obviously. Anytime you do something like this, the patient's jumping. It's just a very, very stressful situation. But the monitoring didn't change, thank God. And everything went well in this case. But these are super high risk for, causing a nerve injury, causing a spinal cord injury. And all these patients pre-op, I tell them it's a high risk of a spinal cord injury, but it's still a better chance than doing it with the more traditional methods. And you could see here, we're taking these chunks one by one, and you could see the dura kind of come into our field. And you're really able to get huge disc herniations out through a tiny incision. And again, like much less morbidity than doing it in any other way. And in this patient, I did have a little CSF leak. I'm not sure caused by me or caused by the disc that was already there. So you'll see after getting all the chunks that I was able to get, there's some that are stuck, I left. Obviously safety first, do no harm. And then after you get as many, as much of it as safely possible, then you could do a dural repair, which really in these transforaminal approaches with a tiny incision with no dead space just means some type of dural substitute and glue, and then closing everything up, and you'll start seeing that now. So you see the dura now. We couldn't really see it at the beginning, much more decompressed. This is the dural substitute that you used, put ventrally just to kind of close off that dead space, and then you put in glue. You turn off the water, put in glue, and then you kind of push it in that way. And like I said, this patient did very well, went home the next day with no issues at all and resolution of his myelopathy. You can see here, it's not perfect. There's still a disc, a little bit of calcified disc there, but way better than it was pre-op. So this is pre-op, and this is post-op. So way better, and he felt better. So obviously I didn't offer him any further operation. And you see that there's a little bit more bony drilling here than in other patients. So great option to deliver to these patients. There are risks inherent to endoscopic spine surgery. Obviously, we don't have much time to go over all of them, but the one that people talk about a lot is, I hate doing endoscopy because I have to wear lead. There's a million x-rays that I have to take. And honestly, after you get comfortable with it, you take a lot less fluoroscopy shots. But another option that you could do is just use navigation. And me and Dr. Abdelbar are working on kind of putting all our data together to look at this. But you really have potential for increased accuracy and decreased radiation exposure to the OR staff. And this is what I use. You have the navigated Jamshidi needle, that whatever system you have. At this time, it was a Medtronic O-arm, but really any system that you have would work. And then you can really take any type of it's SureTrack from Medtronic, but you can attach it to your reamer. And in that way, you're able to really navigate most of your approach. And this is kind of how it looks like. This is more a lumbar spine, but you could do the same thing with the thoracic spine. Instead of using kind of a pin, you could stick this on the spinous process, what's it called, the other probe that's in there. You can stick it on the skin. There are many ways of putting that kind of the base of the navigation on the patient. You could stick it in many other ways. Obviously, there are ways that you could do this using companies that you don't have to stick anything on the patient, like TrackX, but there are many ways, and it just depends on what you have in your facility. So this is kind of some pictures showing how accurate it is. So this was the picture on the O-arm, on the Introp Stealth NCT machine. And then this is how it looked like, the same shot with X-ray. So once you get comfortable with this, then you can really see the power of this, because you don't have to take as many X-ray shots. This is, again, with the reamers that are now navigated. So we did a little bit of a pilot study to show, is it more accurate? Is it decreased exposure? And for a small amount of patients, if you look at really the number of passes, that's the most important thing. So if you look at the number of passes before navigation, it's 6 passes. So it's 6 times to get to that perfect spot that I showed you earlier. With navigation, it's 3. But if you really look through the data, it's all because of one patient that had some trouble finding the spot. But if you really exclude that patient, with 1 or 2 passes, you're at the perfect spot, and you have a lot less number of shots. So I think that's something that's going to be very useful in the future. And there's a lot of companies that do endoscopy that are kind of incorporating navigation more into their workflow. So talked about the learning curve, talked about navigation potentially making it better. Now we want to see, is doing this better than what we're already doing? Because a lot of endoscopy cases are cases that we're doing a good job anyways without it. Thoracic disc, like I talked about before, is a case that is not the case. It's way better than what we're doing. And this is a study that was published earlier this year that showed that full endoscopic thoracic discectomy is safe, and when compared to open approaches, diminishes invasiveness, diminishes the rate of complications, and really decreases the length of stay substantially. And this is proven, again, with a single institution study that showed that even the cost of it is less. So even though you're buying the endoscopic equipment, because you're not putting in pedicle screws usually, you're not keeping the patient in the hospital for a long time during the during their post-op period, that cost of buying the equipment is offset when you're doing these operations. And at the end of the day, we care about our patients, and this is a much less invasive way for them. So in terms of the take-home points, I wanted to kind of let you see, how endoscopy is done in the thoracic spine. I wanted to really harp on the point that I do think every thoracic disc has to be evaluated for endoscopy. Maybe it's not the best option, but it has to be at least evaluated before going through with any type of open option. And then the learning curve can be enhanced by slowly going up in the complexity of the cases. Navigation might help. And now we have evidence to show that doing thoracic disc surgery with endoscopy is better than what we're doing now. So how do I start? There are many ways of starting. Every country is different, obviously. And I appreciate you again very much inviting me, and hope that everybody got something out of this presentation.
Well, Osama, I really applaud you. A thoracic spine is a holy grail of the spine surgery. And we say that thoracic spine pathologies are rare, but as somebody who has done that, they are rare because we don't treat them. They don't make us to our statistic. Know it for sure. Once you have a solution that you can provide to your patient, they come from entire world to you. They come to me. It's a saying that if you do 5 spine surgery a year, you're a specialist. You're a thoracic spine specialist. That sort of old saying that we spine surgeon came up with to tell that we neglect that all the time. Like you showed that thoracic calcified disc. I guarantee you, if you go look at patient history, this has been going on for 5 to 10 years, and 3 spine surgeons, they just brushed over it and just moved on until the patient come to somebody who's willing to treat that. Now, I really applaud you. You are on the right path. We need to find a solution. And I like what you said about the endoscopy. As a neurosurgeon, orthopedic surgeon, they went from regular surgery to endoscopy, and endoscopy is a fantastic tool. We neurosurgeon, we have been using tubular system, macroscope for a very long time. We go through a 2 centimeter, 1 centimeter incision, we clip aneurysm. So doing it small is not a new thing to us. So many of my colleague neurosurgeon, they don't see the advantage of endoscopy because say, I've been doing it for 30 years. What's new? Let me tell you, as you said, what's new is number 1, thoracic. You're absolutely on the right path. And number 2, anything far lateral, foraminal, transcambine, the macroscope is not a good tool there. So now let's not as well dismiss the advantage of regular what neurosurgeons do. With the macroscope, you have a fantastic optical tool that you can see in 3D, and you have 2 hands. Now, the actual value of macroscope is not just magnifying, it brings the axis of your eyes closer together so you can look 3D on the bottom of a tube. That 3D adds a lot. So, but again, I like another thing. You nailed a lots of good things that always consider endoscopy. Bring it to your toolbox, and then it's not like you're dismissing something that would be absolutely perfect for this because you're just not familiar with it. Now, I have to say, like many other tools, you mentioned navigation, which, by the way, I just need to mention, I don't use navigation, even though I have a PhD in computer science. I build those machines. So, to be clear, I'm all for it. I don't use the navigation because in the time you bring the navigation machine in, I'm done with the surgery. But use it as a tool. If it is a tool in your hand enhancing your surgery, absolutely go for it. What I don't like, and I see it a lot, people use the navigation as a replacement for skills rather than as an additional tool. And industry is heavily pushing for that. We have to resist. You need to know how to do regular surgery. And then once you add the navigation and robotic to that, you're unbeatable. But if you try, and that I guarantee you that will happen. But if you use the tool, if you use the robot and navigation as a replacement for your tool and you 100% rely on that, you will come up with bad results because then you don't understand the limitation on that. Like literally, if you use the navigation entirely and you don't know the anatomy, you rely on what navigation machine tells you, even though if you have bumped the DRF, dynamic referencing frame, to a degree, and all of a sudden, when the navigation machine tells you you're in the right place and you're not, but you don't have the natural tools that this surgeon developed to say, okay, let me evaluate that. Am I still in the right place or not? Believe me, that happens all the time. The last thing I want to add to that is that the idea that what you are talking about, that especially in the thoracic region, being able to go and decompress with the endoscopic tools and so on, and you called it the boss level. I like what I heard because yes, don't start with that. Start it slow, and because not about what you can do, it's about are you able to overcome the consequences like bleeding, CSF leak, and so on. You mentioned that. I really love that. But do you mind to elaborate, Osama, and please connect to me? We do a lot of thoracic cases, fusion and so on, all endoscopically with tubular and so on. I think there's a lot of things we can collaborate together. Would you mind to elaborate few minutes about how do you deal in the thoracic region with what complication do you encounter, and what is in your toolbox to deal with them? Do you mind to elaborate on that? Thank you. Otherwise, fantastic talk.
No, thank you so much, Dr. Abbasi, and thank you for your kind words. I appreciate that very, very much, and it's great to see all the great work that's being done by everybody. So, and I appreciate your advice. So, in terms of the complications here, so the most common one is CSF leak, and for CSF leaks, I honestly have never had to open up. I've had a fair bunch of them for sure. As long as you don't injure any neural tissue, especially in the thoracic spine, I think as long as you're able to, put some type of onlay and then glue, I think I haven't had a problem. I know that there are rare occasions that patient comes back and you have to put in a lumbar drain or something like that. So for me, it would be the first thing, first thing would be to onlay, glue. If someone comes back, then it would be lumbar drain probably. And then third thing would be to go back and open up and try to find the leak. Maybe actually even a blood patch. So a colleague of mine used a blood patch once and it actually worked. So probably be blood patch. And then if that doesn't work, then go back in and open things up. So that's number one. Number two, it's having a hematoma. So I think I learned all this from Christoph Hofstetter in Seattle, who's a worldwide expert in endoscopic spine. And he has this thing that he always does. He always, at the end of the case, puts some type of gel foam or some type of thrombin agent in there, and he never closes unless it is pristine. So sometimes it takes an extra hour to do that. But he said that since doing that, he's never had a symptomatic hematoma. And I, thank God, I've had people had pain because of a hematoma, but nobody that's had a neurologic deficit where I've had to go back and evacuate the hematoma. So that's the second thing. I think the way you offset that is being very meticulous, really using the bipolar well, and then at the end of the case, just putting some of the gel foam in there, but you got to wash it out. Don't leave a gel foam ball causing pressure on the spine, obviously. Third thing is the thing that we fear the most is the spinal cord injury. Spinal cord injury is possible. Obviously, you see how much we have to manipulate to get the spine decompressed. I think the main thing first is to say this is not an ego thing. If I'm getting monitoring changes and I'm pulling on something, just leave it, because sometimes just floating it is good enough. Floating the fragment is good enough, and then you can always come back another day and come back and fight another day. But once you paralyze someone, it's very, even if they come back, it's a long recovery. And unfortunately, I'm sure all of us have had it. I've had it, but I think the main thing is to monitor and abort if it looks like things are dangerous, even if you got that last piece, because usually the last piece that causes everything. So I would say just to fight your ego, fight your perfectionism attitude, and just to let it be. Come back and fight another day. The other thing to keep in mind is, you always check the water pressure when you have a spinal, when the monitoring goes down. You want to keep the water pressure below diastolic, even though there is literature coming out soon that says that you could go way higher. But until that literature is out and is vetted, I think just keep the pressure of the water below the diastolic pressure. It's safe to do it that way. I start very, very low and I slowly go up as the case goes on. I'm curious to hear what your thoughts are about that. But I think there will be some evidence that as long as we don't have a durotomy, you can go way up with the pressure, which helps with the bleeding. So that's the other thing. And then the last thing is you could go into the lung. I've had someone get or not me, thankfully, but a good colleague of mine who's a great surgeon got a hydrothorax, because I think he went through and through with a Jamshidi needle and just filled the whole thing up. And he noticed that he wasn't getting much water back, but didn't think much of it. And at the end of the case, the patient had a hydrothorax, had to put in a chest tube. Patient did great, but that's something else to keep in mind for thoracic cases. So those are the four things that I would say are probably specific to doing thoracic endoscopy.
Well, thank you so much. That's extremely helpful. And I just want to get a hand count here. All of us do ACDF, and I'm just wondering how many of you have had dural leak during the ACDF. I'm going to raise my hand. And I think there's some probably parallel between the dealing with the dural leak in the ACDF and endoscopy, because the space is narrow, the manipulation is very, very limited. And I just want to show you something that I do for my ACDF leaks. I want to understand if that is from you, because I'm not expert in endoscopy, and Dr. Munshi is as well here, who's an absolute expert in endoscopy. I want to see if something like that is applicable in the endoscopy or not. So I'm just going to quickly share my screen. And I want to learn from you if that is an option. Are you able to see my screen? In the ACDF,
Yes.
you are between this is anterior, this is posterior. You go through the disc base, and all of a sudden you have a calcified disc, you have something, you decompress, and you have the leak here. What I do these days, and it has been successful, is that I cut a small little piece of fascia or something tough, not like, or some material that is thin, but is like a fascia quality. And I literally make it a little bigger than the leak, and I tuck it underneath, under the, in the intrathecal under that, because in this case, the pressure of the CSF, I let it run. I let it drain a little to reduce the pressure. And then I literally, by putting a small patch underneath, the pressure seals it like a valve. I still do the traditional way, put a small little, muscle or fascia above, and then I use some sealant material. And that sealant material that I use is, I try to use something that not hydrates and get bigger, because some of them, as you know, they hydrate, they become bigger. And so I put that material just on top, spray on top. Now, I know that, I use two hands, and I use it like a nerve hook. I put that layer underneath, and I literally tuck it underneath. Is something like that, Osama and Dr. Munshi, is something like that would be applicable endoscopically? Do you have enough tools and different kind of tools to be able to tuck something on the other side, inside of the dura, that work like a valve to stop the dural leak?
So I'm curious to see what Dr. Munshi thinks, but I think the answer is yes. For sure with bipolar endoscopy, 100%. With unipolar endoscopy, you usually are able to kind of feed things with one instrument. There's a way of that I learned from Dr. Hofstetter, is you could get some type of K-wire that's very thin and bend it at the end to become like a hook, and then you could put it through one of the irrigation ports. So then you really have, and you ask someone to hold the scope, then you have two hands. It's not the best two hands, but it's like it's good enough. So I think that's one way of doing it. The second thing you could do, if you really want to do this, I'm not sure I would do it, because then you're creating more dead space. But you could add an accessory port if you're doing an interlaminar approach. Then you have two hands as well to do something like that. But I think for me, I think it's doable with one hand, just with the bipolar or with the probe. Worst case scenario, you can bend a K-wire and use that as a second hand. And then worst case scenario, you could you put in an accessory port or open up.
So what I do, I use a number 8 sucker on a very low suction, and I put literally that, let me show it to you here again. And I'm just wondering, certainly I couldn't imagine how to do it with one hand. I put the sucker on the low suction. I literally put here and then I use the hook to tuck in one end of the graft in, and then I go around while I'm using the sucker to go around, and it works pretty well. You just have to cut it the right space, that it literally is just a little bigger than the hole you have. Most of the time the hole is not really big, but I think doing it endoscopically is a mastery of the technique. Dr. Munshi, what do you think? I think you're muted, but
Yeah.
for those
Yeah,
who
see, normally through the endoscope, if we have any dural tear, then because of our port is the only small port, so most likely, like, we have to see is there any dural gap or only dural tear. So we suppose if the rootlets are not coming out, and if there is a small tear, and it's like a self. Usually, it's a self sealing, and you don't need to do it anything else. but sometimes like even just take a one central suture, and we have developed a small device where you can like the laparoscopy, you can take the suture on the both side, and one small suture will do the enough of the job, and then over the suture you can put you can put the platelet plug or some port or some portion of the fascia. But in my experience, endoscopically dural tear is usually where we don't need anything to do uh, for that. And like I have around 8 or 10 dural tear, but none of them were even symptomatic. Even
Yeah.
one month post op MRI, they were quite okay. Okay, Dr. Basi, I have like a few points about the thoracic disc especially. So you see, currently, uh, uh, what I feel that the thoracic disc doesn't have that much space to accommodate most of the standard transforaminal lumbar endoscope, because most of the lumbar endoscope they are ranging from 7 to 8 millimeter. So you have the dilator is go around 8 millimeter or something. So this is like a more traumatic to the end plates. So I joined this session halfway, so I don't know. But like I just want to give 4 5 points which I usually follow. So normally to avoid the lung injury or the pleural injury, I always take the CT scan before, and then I make my entry point planning before. So that is one thing. Suppose if I have a more of a central herniation, then I land on the lateral part of the lamina, and then I make a little drill, and then I try to be more flat, because you don't have much scope in thoracic area to become more lateral. For that we have developed a very good, a very small scope, which is 4.7 millimeter, and you get around 2.3 millimeter working channel. And the third thing, and the most important thing about the endoscopy is when you have small kind of a bendable or flexible instrument, that is one of the key to take care about the herniation, which is more into the center, because again you cannot go more lateral. And the most important thing, what I believe, that I do all of my surgery in the local anesthesia. So here, because you see, this is a simple small trick, and you just have to anesthetize the skin, and then you anesthetize the subcutaneous area in the small muscle. So hardly you go around 5 6 or 7 centimeter from the midline in the thoracic area, and then even when you reach to the bone, so the only the periosteum is pen sensitive. So you just infiltrate on the bone, and then you reach to the disc. Even you infiltrate on the disc, so usually the patients are quite comfortable. And the most important that we believe that awake patient is the best neurological monitor. So like you can get all kind of feedback from the patient. And most importantly is the this is the angle of the endoscope. So you have usually 30-degree angle of the endoscope. So you are able to visualize the things which are even on the more on the dorsal side. So that is also one of the very important factor here, that this angle of the endoscope is able, you are able to visualize. And one extra advantage, that you can use the facet as a lever. So like when you want to go more of the dorsally, you just have to pull down the entire assembly. So automatically you become more dorsal. So that way it's like quite easy. And now out of the box, like see, even when somebody has a disc herniation, so I actually divide this patient into two groups. When somebody is having the acute disc herniation and it's giving the neurological issues, then we have to take out the disc. But suppose if I have a patient with a chronic calcified herniation, and the patient comes late, and so many other trial has been done. So I try to I try to see the patient's previous MRI, maybe 2 months or 6 months or 1 year old, and the fresh MRI. And if I don't see that now the disc is bulging or disc is moving further, then in those patients also, just doing the only posterior decompression with the good foraminotomy is more than sufficient, because here also when you remove the disc, so you are actually making the disc space more collapse. So like this is the like initially we used to do a lot of transforaminal and we used to take out a lot of disc, but then this is more about the lumbar area. So then you have the subsidence and you have these issues. But now, if you have the calcified disc and if the disc is stable, stagnant, and if it is not further progressing, even doing the posterior decompression with foraminotomy is one of the very good option. And usually those patients do very well also.
Thank you,
So
Dr.
this is true
Munshi.
for the lumbar, cervical, thoracic. This is true for all the levels.
Thank you, Dr. Munshi. That's very, very helpful. Now, I see my good friend Dr. Kailash is here, but Osama, you said something that I want to follow up as last thing because we have to move forward about that you use kyphoplasty to mark the level. I cannot emphasize how important it is that doesn't matter how long you have been in spine, it identifying the level in thoracic spine is a big deal. I can tell you from my own experience that I was doing surgery with my teacher who was a 40 years spine surgeon. We counted from above and below for 45 minutes. That is 20 years ago. We still were wrong. So it is a possibility. And what you said that marking the level with the kyphoplasty is very novel. It's great. As well, there are some ideas that you do that put a jamshidi in the, and then you put a small little ball bearing or a small little metallic thing in the vertebral body. Get a CAT scan if you don't want to do kyphoplasty. It's a great idea, but in many parts of the world, that will add to the cost of the surgery, obviously. But what you can do literally, this is what I have been doing for marking. Most of the time, the K-wires, they are biocompatible stainless steel, and they have a very good signal. If you don't want to spend the money on kyphoplasty, you put your jamshidi like kyphoplasty, and then you cut a small piece of your K-wire and you push it in, and then you get a CAT scan. That as well works very well as a marker. Dr. Kailash, you want to comment on the identifying the right level? Because with your experience, I really want to spend a little time for that, especially for a younger surgeon. Do not ever trust your counting. Do 5 more times counting in the thoracic spine. You would be surprised how often you will. Now, certainly somebody had a bone fracture, some pathology, calcified disc, and so on. That's a different story. Previous hardware. On a spine that you don't have any of those, do not ever take it lightly. Dr. Kailash, what tools do you use for right identification in the thoracic spine?
Yeah, at the outset, Hamid, thanks for sending me the link to one of the lovely evenings. And it's a Saturday evening, so it's I'm sitting glued listening to Dr. Kashlan, and it's really worth being glued to it. Thank you for that lovely talk. It's a pleasure and privilege to hear you. And coming back to what Hamid is asking about it, we come from a poorer background compared to using white kyphoplasty. So I use the same technique as what Hamid's doing, but I use an 18G disposable needle. I take the patient on into the CT scan room and then mark off with the 18G needle and then put a dynaplast or sticking tape onto it. And I also mark a razor wheel and flare at the interdiscal area so that I have 2 markings going on. Because in the initial phases, when we let the resident of the fellow go and mark it, the sticking plaster fell off, the needle fell off, and then we were back to square one. And there have been n number of times where I have to admit shamelessly that I have done a wrong level laminectomy. I've gone up to one more level again, done an added laminectomy after that. And these things we have had in the last 15 to 20 years back. But now with fluoroscope as well as with the CT scan, we have a very clear idea that we put the needle in, put a sticking tape and raise the wheel and flare, and it's there for us till the next day for us to go ahead and do it. So that's that's a cheap way of doing it for us because it's inexpensive. And kyphoplasty is novel. It's brilliant.
Yeah.
It's brilliant.
I thought so too. No, but if you don't have the access to now put something in and come back next day, and if you have to leave something behind, obviously kyphoplasty is there forever. And as well, literally putting a small little metallic biocompatible material in and then get it like CT, and 3 months later that piece of metal still will be in the same vertebral body. And even if you have to put screws in, it won't be in your way. Yeah, like I'm talking about the 2 mm tip of, literally cut the tip of the K-wire and put it in the Jamshidi needle and push it in the vertebral body. But yours is even better. It doesn't leave any other thing behind. Well, I think we should thank you so much, KK. The next talk is Dr. Sameh Abdul Fatouh. I would say we just move forward to be conscious of your time. Please move on.
Well, thank you very much for the invitation. I really enjoyed the previous talks from my friends and colleagues, and the discussions are actually very fruitful as well. Let me see here if I can share my screen. All right. All right, you guys see my screen? All right, so those are my disclosures. I consult for a few companies. I sit on the advisory board of others, but none of those are related to what we're talking about. As everyone was talking earlier today, we're just talking about how technology can be helpful, whether it's endoscopy, whether it's navigation, robotics, you name it, because it seems like we're moving in that direction. As Dr. Hamid mentioned earlier, companies are pushing in that direction. The market is pushing in that direction. And it seems like we're going to be using more and more of those in the future. So this is part of our practice in our hostel. Sometimes it's one of those, deformity surgeries where long time ago, lots of flat backs were done, and we go ahead and we do all of those 3-column osteotomies, try to put the head of the patient on top of the pelvis so that they have less effort when they're walking around and doing their daily activities. Sometimes it's a deformity that has been ignored for a very long time. And once again, you go in and try to do all the osteotomies to correct them. And sometimes it's something as minimally invasive as a 3-level ATP, where nowadays those surgeries are really helpful and they help patients get out of the hospital very fast, as was presented earlier today by some of my colleagues. But what's common between all of those surgeries is that your life can be much easier if you're using spine navigation operating those. Now, if we take a look at the literature between 1960 and 2010, you realize that almost 1/3 of the literature that did come out in spine surgery was actually about image guidance. And the history of neurosurgery, I'm an orthopedic spine surgery, and it hurts me to say this, but the history of neurosurgery is very rich. This is Bovie, by the way. Bovie was a neurosurgeon, and I can't imagine a surgery that's done without a Bovie today. Obviously, the introduction of the microscope helped us doing all of those fancy surgeries through very minimally invasive approaches. But it wasn't really till David Roberts in 1986 who was the first one to introduce the idea of stereotactic integration and tomographic imaging using a microscope, a concept that was 1 year later popularized by Watanabe as well. And I cannot think of a single brain surgery that's not image guided nowadays. So the concept of navigation the way we know it nowadays was actually introduced in 2007 with the introduction of the O-arm. And that was way before Medtronic acquiring the company for $4.7 billion. And I had the pleasure of visiting that facility in Colorado. And it's true that that facility, there is true magic that's happening over there with all the innovations that they're coming with every single year. But nowadays, it's not just having that intraoperative CT, because we have several companies, we have those 3D C-arms that are pretty much doing the same job that an intraoperative CT is doing. And whatever you get your hands on can basically do the same job at the end of the day. So the question that I ask myself and I tell my residents all the time, why image guidance? Is basically because you want to be accurate and you want to be precise whenever you are placing those screws, and you want your results to be reproducible over and over again. Now, growing up as an orthopedic spine surgeon in my orthopedics residency, I used to hear all the time from my mentors stuff like this: navigation wastes my time. There is absolutely no point of using it. This is for neurosurgeons. As orthopedic spine surgeons, we tend to have a lot of ego. We trash talk neurosurgeons all the time. I'm pretty sure they do the same as well. And it's unnecessary bulky piece of equipment that takes a big part of my OR. And the one that used to kill me whenever I hear it is that this is for beginners. I'm too good to be using navigation. But the truth is, we're not as good as we think we are. Because if you take a look at the literature, and this is one of the most famous meta-analysis that was published back in 2014 that included 30 studies. One of them was an RCT. And basically, they wanted to check the accuracy of the position screws, and they used a post-operative CT scan for that. That's a study that included almost 2,000 patients with almost 10,000 pedicle screws. Now, let's take a look at the results here. So when you're using a freehand technique, your accuracy is somewhere around the 70%. Now, when you're using an intraoperative C-arm, your accuracy goes all the way up to 85%. And when you're using navigation, it goes all the way up to almost 95%. Now, I can hear you. Some of you would probably say, well, who cares if it's 70% or 95%? Because at the end of the day, that doesn't mean that those 30% that I missed are going to end up having any neurological deficits, right? And yeah, you might have a point with that. But the truth is, we live in a world where okay is not good enough anymore, right? And that patient that you malposition screw in can walk into another clinic in another company, in another country, even in the same country. And at the end of the day, he can file a lawsuit against you. And let's face it, that's becoming a big part of the practice nowadays. So David Pauly, who just retired last year, amazing surgeon, was a friend to the majority of you, I'm pretty sure, wanted to know why is it that we miss that much whenever we're putting those pedicle screws. So he conducted a study where he got cadaveric vertebra and he created an iatrogenic breach in the medial wall of the pedicle. And then he asked all his staff, including his junior residents, senior residents, fellows, junior attendings, senior attendings, and asked them to probe that medial wall of the pedicle, or to probe that pedicle, right? Let's take a look at the results here. So even in the hands of the experts, and those are the senior attendings, this is one of the busiest deformity centers in the world. You can see that 20% of the time, they didn't feel that breach in the medial wall of the pedicle. And those are the experts, or at least the busiest deformity surgeons out there. And as I talked earlier, because screws can cost millions and millions of dollars. And that culture is moving also to the Middle East nowadays. And it's not just an American culture of litigation anymore. It's moving all over the world, becoming a great issue that healthcare industry needs to deal with. We don't also think a lot about radiation. I mean, a lot of my colleagues raised that earlier today, but we rarely think about the amount of radiation that we're exposed to in the OR every single day. My previous partner, who is a neurosurgeon, who had a thyroid cancer at the age of 37 and got operated in the same year, simply, well, while I can't swear this as a result of the radiation, but you're using crazy amount of radiation, and we're exposed to crazy amount of radiations every single day in our OR. So a number of years ago, Roger Harrell wanted to know, why is it that apart from any other specialty in surgery, spine surgeons tend to be late adopters to technology in general? And it is true, right? So you can see the robot has been widely used in neurology and has been adopted very early, but in spine surgeons, we tend to be very hesitant in adopting the technology. So he conducted a survey and he distributed that survey through the AO network on all the AO surgeons back there in 2013. And the number one cause that surgeons were resistant to adopt technology is basically what Dr. Hamid mentioned earlier, is that it disrupts my workflow. He mentioned earlier that I can be done by the surgery by the time they get that navigation in the OR. And I 100% agree with them, because our ORs are becoming very busy nowadays. You can see that the anesthesia machine is up there, the microscope, the CT at the upper head of the patient is becoming really, really busy. And let's face it, not every single OR in our region can accommodate all of those stuff in a single OR. So let me switch gear here and talk about spine robotics. And Muhammad Abdelbar did earlier highlight a little bit of this. So in 2017, when I was in the University of Missouri and the Globus Excelsius just got FDA approved for the first time, and we decided to try it and to do a single level TLIF using robotics. Now, I was very excited that night. I didn't actually sleep because we were going to use the robot on the next day. And all the thing that I could think about back then is seeing something similar to what we see in the movies. And unfortunately, I walk in the morning and I see that ugly piece of machinery in there in the OR. But if we think of the concept of automation in general in surgery, it's a very old concept. This is a picture that was taken from the Fyodorov Institute in Russia, and it's the number one center in the world for ophthalmology. And you can see here back in 1980, all right, the surgeons were sitting in a circle and the patients were rotating where the patients are to be able to help more patients with cataract surgeries instead of the surgeon moving from one room to another or from one bed to another to operate on those patients. So it's a very old concept in surgery in general. Now, here's an article that I came across in the Washington Post, and it basically states the 5 most jobs that are going to be at risk over the coming few years. And number one is middle management. And to be honest, I don't care because we are going to finally get rid of all of those boring managerial guys in our hostels. Salespeople, that kind of makes sense. Reporters, bookkeepers, as long as it keeps out of prison, I don't really care if it's a robot. But the ones that we obviously should care about is doctors. And that's obvious every single day with the technologies coming with AI and robotics. Now, this is a picture of the first surgical robot. This is the Puma. And you can see here some of those pictures and advertisements that didn't make any sense. Here is a guy who's fully dressed with a suit and a tie, and he's probing the brain of a patient, and she's very excited about it. Some of those early advertisements didn't make any sense, but the Puma is actually a robot that's still being widely used in some of the centers out there with neurosurgeons, just to take some biopsies as well. And you can see that the concept was very preliminary when those were introduced. Now, it's very important to mention that part of the big breakthrough technologies in surgery in general were actually funded by the military. And the Da Vinci is a great example of this. So the idea of the Da Vinci when it started is that it's a robot that we want to be able to operate on the Marines in areas of the world of lots of conflicts with a surgeon who's sitting on the East Coast or the West Coast without the need to travel all the way to areas of conflict. Obviously, they didn't end up with that. They ended up with the Da Vinci that's widely used everywhere in urology and general surgery nowadays. And that was a breakthrough because it got us to where we are today with robotics. So nowadays, in a spine robot, you can pre-plan your screws in advance. Obviously, as Muhammad Abdul mentioned earlier, it's not yet FDA approved for pre-planning of positioning your screws, but it can be really helpful, especially with the case with grade 4 spondylolisthesis, where you have only one shot of getting that screw in place because of the deformed pedicles, for example. So it can be a very helpful gadget in our ORs nowadays. Now, here's another article that I came across in the New York Times that it basically states that whatever skills you develop as a child is basically going to dictate your skills as you grow up as a spine surgeon or as a surgeon in general or as a healthcare advocate as well. Now, if you take a look at the older surgeons, they didn't have anything when they were younger, right? Because they didn't have iPads, iPhones, all the technology that we have nowadays. They basically had nothing apart from building those wooden blocks and trying to build stuff. So, and that made them the surgeons they are today with the great skills and the stereotactic techniques and all of this. But if you take a look of where we are today, millennials are actually operating on patients. And those are the people who grew up using all the fancy technologies and gadgets and iPads and iPhones. So it kind of makes sense introducing what they're good at into today's technology and into today's surgery as well. Now, I can present you with all the data that can tell you that robotic surgery is going to save you money and it's going to decrease the number of patients going back to the OR. And I can also present you with all the data that can tell you the opposite, that robotic surgery is very costly. I think it's something that we're going to figure out down the road as we have more data over the coming decade or so. It's too early at this point for the healthcare industry to say whether a robot is saving money really or really an extra cost that's totally unnecessary in our ORs. Now, if you talk to a guy like Alex Vaccaro, now Alex always gives those lectures against spine robotics. He uses a robot in his OR, but he gives those lectures all the time. And his rationale is nowadays we're not looking at our patients anymore. You walk into those ORs and you can see us looking at those screens all the time, trying to figure out the trajectory of the screw. And I agree with Alex because the first thing we teach our residents is don't take your eyes away from the patient or from the operating site. Now, I think that's something that can be overcome nowadays with augmented reality as well. Now, the concept of augmented reality, as I said, every breakthrough that come from the military, this is a picture that was taken from one of the fighters out there. And you can see that this is an application of augmented reality on seeing your target, the number of missiles that you can see on the glass over there. You can use it nowadays in placing a nice piece of furniture in your home and see how it looks before you buy it. We all remember the Pokemon game a couple of years ago when there were authorities were issuing all the warnings that kids are going to get hit by a car because they're walking around playing with it. Even working home after a long day in the OR and using that heads-up display, that's another application of augmented reality. But nowadays, we can really see with augmented reality where everything that's happening on navigation, you can see it right directly in front of you without the need of looking into those screens. And with the help of some companies like Brain Lab, you're actually able to see as well the integration of the MRI in the middle of surgery. So I always tell my residents that the surgery that I hate the most is a microdiscectomy. I have no problem fusing a patient all day long and doing the deformity surgery. Microdiscectomy, there is no disc that's like the other. You always underestimate it. You book an OR time that's very short, and the majority of the time it takes like that. This is a very fast surgery, but sometimes we have those nasty discs that where's the disc? Is it in the shoulder? Is it in the axilla? And all of those stuff. But all of this stuff is going to be part of the past because you can now know exactly where your pathology is. And imagine if you're doing a tumor surgery and you're wondering whether you got the whole tumor out or not. Now, nowadays, you can do all of this with navigation as well and the integration of MRI as part of your surgery as well. So for me, I don't know if you guys heard about Simon Sinek, and Simon Sinek is a great motivational speaker, and he has all of those fancy books. And he always talks about that golden circle, that as spine surgeons, we always think of what the problem is and how to fix it, but we really think about the core of the problem, which is the why. And for me, technology in spine surgery nowadays is all about your efficiency, because ideally it should help you with the workflow. If you get to that point where really fast doing technology can help you all of those fancy surgeries through very minimally invasive approaches. But in my opinion, the most important thing is safety, because every single day should be a patient safety day. So the faster we hop on board and we adopt technology and stop fighting against technology, the easier it's going to make our lives in the future. Thank you very much.
Thank you very much. That is a fantastic futuristic view of what's going to come. And just to be clear, I think all this technology will enhance our abilities. Now, I have a problem, though, that you don't never learn to do regular spine surgery. And if your machine doesn't work, you have to cancel the case because you don't know how to do regular surgery. They need to be a tool in our toolbox. They're very helpful tools. So, in 1993 to 1998, I did a dissertation in virtual reality medicine. I used this kind of enhanced reality enhanced, so-called the virtual reality headset and so on. The technology wasn't as far as it is now. As a matter of fact, after 5 minutes, you would be nauseous having those head-mounted displays. And as well, in 2000, I built a neuronavigation machine for spine in Stanford. It used to be called Sibion. I am an early adapter, but I think as an early adapter, you have to as well understand the limitation of the tool you're using. Don't use a screwdriver, Phillips screwdriver for a flathead. You're going to just fail. So now, having said that, I'm very interested, Dr. Sameh, on that statistic you showed that about 70% accuracy with the freehand. Certainly, there are studies that show that. There are some other studies that show higher and even lower numbers. Is there any study that shows the double C-arm technique for percutaneous? Because I think that is a category of itself. So there is a freehand, there is a X-ray enhanced, then there is obviously navigation and so on. But is there any study that shows the double C-arm technique? Because I can, from my experience, I can tell you that is a category of itself. And I can tell you if that's what I use and the colleagues that I know, if our accuracy was even 90%, we would be in big trouble. You're absolutely right about the medical legal side of it. If our accuracy was even in 90% with double C-arm, we would be in big trouble. Is there any study that shows double C-arm technique compared to other techniques?
So thank you for your question. I actually didn't come across a similar study, but I'll tell you what my problem with the double C-arm is. First of all, it definitely makes your life easier because you're not losing time moving the C-arm from AP and lateral. But it also makes your threshold, if you're a beginner surgeon, not an expert like you, it makes your threshold to taking shots much lower, right? Because you're thinking twice before moving between that AP and lateral view and asking your technician to move. But if you have access to that view every single time, what I realized over time that people who use the double C-arm instead of single, that they end up with a larger number of shots instead of what you regularly use with a single C-arm. Now, back to your point about learning about the normal open classic or freehand spine surgery. That's very important. And I think that's the challenge that we have every single day with our residents and fellows. Because all of them, they walk in, they want to use all of the fancy technology and all of the fancy gadgets. And hostels are buying them nowadays because they want to be competitive in the market because the nearby hostel did buy a navigation machine or did buy a robot, correct? And that's how hostels market themselves nowadays. So I think what we worked on in AO over the past couple of years, when we did put the guidelines for centers to be accredited, whether they should be AO centers or not in terms of fellowships, that at least 20% of the screws that should be done by a fellow in a year should be done using navigation or robotics, because they also need to learn that part of the technology, because that's where the part of the market is heading. But also 80% should be conventional surgery. And by conventional surgery, that means either freehand or using a C-arm or whatever it is that's not using fast technology. So I agree with you, it's a challenge. Obviously, standard or conventional surgery is a no-brainer. It's something that should be learned, something that every surgeon should know before moving to using those gadgets.
Absolutely. Now, I was giving presentation in 2023 in Seattle Science Foundation, and there was a presenter who was a faculty in Stanford. This is, I'm literally citing word by word, that they are considering sending their resident outside of the United States because they don't get enough exposure to regular freehand screw placement. I think that is a dangerous. It doesn't even need to be 80%, even 50%, even 40% freehand training with a freehand, I think is suffice. But if a prominent place like Stanford considering sending their resident outside of the United States to get exposure to freehand techniques, I think we have a problem on our hand. That should be a main curriculum. Kailash, Dr. Kailash, I know that your residents are fantastic. Your fellows are great, but what's your take on that? How much technology versus freehand, old-fashioned skills? What is the right combination in percentage?
Yeah. Thanks, Dr. Sameh, for a lovely update on what is new and what is it. And to be fair, we have the navigation system in our hospital, and we use it only for very difficult deformity work or for cervical pedicle screws if needed. Most of our work is done free, and even cervical pedicle screws. Even this morning we had cervical thoracic fixation. We did freehand without navigation. So in our institute, we deem it that at least 50% of our cases are done freehand and using C-arm, which could be either minimally invasive or which could be open surgery. So 2 days in a week, we have 4 days theater. 2 days in a week is allotted for the residents for them to go. So at least it varies between 30 and 50% of the cases, which means that they have adequately trained in 2 years of time when they work with me. They get to see about 1,500 surgeries or assist 1,500 surgeries a year. So in that, they are adequately trained in open surgeries. We have had some people coming in from other institutes where only minimally invasive with navigation is being done. And it's been terrible that they don't know. Just as Hamid is saying, we absolutely found it terrible that these guys didn't know how to put an open pedicle screw. They were struggling. It's like one of my colleagues, who did arthroscopy. He had a compartment syndrome, and I had to go and bail him out doing a fasciotomy because he didn't know how to do a compartment syndrome. he moved into arthroscopy directly. So this is the kind of scenario we are getting into now, and more so in our country because the Tier 1 towns, the metros are pretty well equipped. The Tier 2 and Tier 3, where the guys come in to get trained with us, go back and they don't have the gamuts. So the gadgets are not available. So we are insisting now, just like what you did, mandatorily the guys have to do open surgery, and at least 30 to 50% are done that way. That's the only way we keep them going.
Excellent. Well, I think we are coming to close. I think it's my turn now. Dr. Altier, is that correct? It's my turn? So, and I'm going to keep it short. This is practically a talk I have been giving about the transcaminolif and the so-called oblique lateral posterior lumbar interbody fusion. And I'm going to keep it short and concise because most of you probably are familiar with most of the content I'm going to give you. Are you able to see my screen?
Yes, doctor.
Excellent.
Yeah.
So let's start.
Yes, yeah.
And I'm going to try to keep it under 10 minutes. Now, all of us, we are in the right field. Spine is number one reason for disability. Know it. And it's going to get even more. The numbers are going even to increase. Why is it important? It is important because the numbers of the patient we have to deal with is going to increase, and we have to be efficient. Now, by the time you are 70 years old, there's only 2% chance you don't have spine problem. Thank to the Lord, we don't have to do surgery for all of them. But that number is going to be increasing. Now, this is beyond this talk. We have method truly to help the patient without the surgery, but number of the surgery that are going to need surgery is going to increase. This is from 2022, 1.62 million spinal fusion in the United States. And if you think it's a lot, the rest of the world is catching up with us. I remember my parents were in horrible pain the last 5 years of their life. They were miserable and nobody could help them because there weren't enough resources there to help them. Now people have the resources, they want the help, so you will be very busy in spine. You chose all the right career for yourself. Now, one of our other doctors was saying, I think it was our first presenter, it's not about Dr. Albara as well, it's not about the skin incision. What happens under the skin makes the surgery minimal invasive. All the muscle that you don't detach, that you don't reduce the autoregulation of the muscle, that you don't cut the vascular supply of the bone. That is what makes truly minimal invasive. This is a patient of mine. In 2012, I did a 2-level TLIF. On the left side, you see everything 6 months later is scar. There's nothing really viable tissue anymore. In 2014, I did adjacent level OLIF. In 2016, patient had a car accident. I took the patient back 2 years after the OLIF, and you see where I did the OLIF, transcamin OLIF, it's a pristine tissue. That tissue helps the patient to recover faster. So muscle sparing, doesn't matter if you use OLIF ATP, XLIF, ALIF, muscle sparing, you really put your patient on a better path to recover. This is how scar look like. You see multifidus muscle are gone. You see the abdominal and muscle and so on still intact. And even 2 levels above, you see that multifidus muscle here, up right, you see 2 levels above the index level, the multifidus muscle has turned into scar. So you need to know that these are not harmless techniques. So I was very happy to see that even in this complex surgery, the Wilsty technique is used to place screws because that will increase the viability of the tissue. And as well, let's talk about the efficiency of the surgery. Okay, this is a fact based on almost 400,000 surgeries, all surgeries together. Every additional half an hour on the anesthesia adds 17% to the combined risk of the surgery. So if you put the surgeries that are under 2 hours in one group, surgeries that are over 2 hours in another group, you're doubling all the complication rate related to the surgery. Now, Do not misunderstand me. This is not a free card to just speed up and artificially do a faster surgery and cutting the corners, because then you quickly will undo all the benefit of that. But if you can perform the same surgery with the same result in a shorter period of time, patient will benefit from that. I will come back to that. Now, let's just talk about different approaches. And we just heard that every day another person adds another letter to the or lifts. Now, I'm not going to talk about all of them, but let's first of all understand that there are different approaches, and I like these anatomical approaches. I'm not going to talk about axial lift and some other obscure ones, but mainly mostly performed surgeries you see here. And obviously the transcaminal lift is, by definition, you are going through the transcambine approach in a cambine triangle or prism, as you may want to call it. And it avoids posterior element, but as well anterior element. And it's in the prone position. That is, I think, the main advantage. That's all in prone position. And you can literally go from T5 to S1. Obviously, in the T5 and to T12, we don't call it OLIF, we call it OTIF, oblique thoracic interbody fusion. They are different. That is a boss level that our other presenter was describing. You don't start with that. But literally in one position with the same instrumentation, you can go anywhere from T5 to S1. Now, this is they ask me, is it the only thing you do? Because if you just hear what I present, you would think I have only one hammer and I hit it. Everything is for me a nail and I hit it with Olaf. Well, I don't give talk about other things I'm doing, because I know lots of people are more expert in that and so on. So don't misunderstand from what I present that transcambine Olaf is a one tool for everything. But it has to be a tool in your toolbox. Without that, you're missing a lot. Now, if lordosis is your priority, and for some patients it should be, you don't do TLIF or transcambine OLIF. You do OLIF ATP, XLIF, ALIF, where you put a ginormous cage with the lordotic curvature to correct that. If your priority is the direct decompression, like literally a piece of bone sticking into the dura or the neural element, then you do have to do a direct decompression. Now, the reason you don't hear me talking about that, because there are lots of experts there. I don't have any additional expertise there, but I'm going to share my additional expertise with you when the efficiency is the issue. Now, how many of you are going to do a 3-level ALIF or TLIF on an 88-year-old patient with the ejection fraction of 35%, who 5 other surgeons have refused to do surgery? Well, that is my patient population that they come from entire United States to me, because we do with our technology, not only I, anybody in our board, do that surgery in 1.5 hours, patient ambulates same day and goes home next day for the last 12 years. So let me talk to you about this. And we have published now 12 papers. And as of yesterday, this is now a few months back, but as of yesterday, I have done 2,045 cases. This is from July, so obviously this number changes every day. And about 40% of our cases are under 1 hour. I'm talking about complex cases. And 99% of our cases are under 3 hours. And that efficiency, again, not cutting corner, but just having a method that make you efficient, enable us to help a lot of patients that couldn't get an option until now. This is one of the hospital I'm doing surgery. ALIF. These are good surgeons. They do anterior, break the scrub, reposition the patient, put posterior screws. 6 hours, 9 hours, 2 level. We do that surgery usually under 1 to 1.5 hours, and that enables us to help a lot more patients. Now, this is obviously not obscure finding that is still happening. 1 level fusion, 7 hours. Now, I saw lots of lifts and so on, But I think we can all agree, you need to be, no matter what you do, a 7-hour surgery for one level fusion is excessive. You need to have better option than that. But this is still happening. Don't look at conferences and people you go and talk to. Reality in the ground is very different. This is our study that we published that shows, even though, as it makes sense, with higher BMI, the red line, the TLF becomes more lengthy, and the other thing correlate with that. Bleeding, infection, hospital stay, return to surgery, or all go with this line. MIST-LIF is a good surgery in the experienced hand. It is superior, seems to be superior in risk profile, up to BMI of 37, whereas we could show with the transcaminolif, we can even do now BMI up to 60, 64 without difficulty. It opened up the field for lots of cases you wouldn't even consider to do surgery. I can tell you, you do not want to do a ALIF, I have done it, XLIF or OLIF ATP in somebody with a BMI of 50 and so on. Whereas this, for transcaminolif, is a routine surgery. Our patient ambulate within the first 24 hours, and actually 6% of them. Before I come and give you a talk, I just went to the hospital and I discharged all my patients from yesterday. So, and 2 days before that, I did 7 surgery in one day. Every single patient was discharged within 24 hours. So this become a routine thing, and not only for me, for everybody who follows the algorithmically the steps of this. Now, I'm going, instead of talking about the data and so on, and I have plenty of that, I want to show you this slide, one more slide, and a short video. See, right now, in the United States, and in the other countries, this may look different. Less than 3% of the lumbar fusions are performed in the surgery center. Vast majority are performed in a hospital. And there's a huge number of cases, which makes about 40% of my cases, are cases that other surgeons, multiple, have rejected the patient for a good reason. They are good surgeon, they know risk versus benefit is not justified. So there's a huge reject for spine surgery, elderly, high BMI, comorbidities, somebody who has COPD and they cannot tolerate 4 or 5 hour surgery. What we can show, and what you see here as a future, is my practice right now, that more than 50% of my patients are performed in a surgery center setting, sent home same day. And there's a lot of patients that wouldn't have a choice, that now they have a choice now. And all of that is done with a handful of tools. You don't need $1 million robot or literally a $150,000 annual maintenance fee for a navigation machine or a robot to perform this. What you see here is all what you need. And that is why I'm proud to provide this to the rest of the world, where in any small hospital, anywhere in the world, you can do this surgery, but this is literally the table. This is all you need. This is all you need to do entire surgery. The front table, the back table, you don't need all of that tool there either. And then I'm going to show you a small video now. So literally, this is a ischemic spondylolisthesis. I'm not going to show through the indication because that's a different story. But here is where we start the surgery. AP and lateral. And that is what I'm going to tell you. It's extremely important. You can do this surgery with one C-arm, with navigation, with other things. But I can give you the data the way I do the surgery. We start the surgery with double C-arm. We mark the level. We then literally put a Jamshidi in the first level of interest, take bone marrow that we mix with biologic. And we have our own protocol. I use a ceramic tricalcium phosphate, which by itself is a poor biologic, but in mixed with the bone marrow, it's very strong. We use a neuromonitoring probe, stimulate at 3 milliamp. We go to the Cambin triangle and then literally dilate it. And if you see the anatomy changes right there, that's what I call physiologic decompression. We published a paper about it. And then we put a tube in, it's 8 millimeter inside, 10 millimeter outside. There's a very specialized tools that is now available to everybody. We just, through Kambin's and Avicenna Society, we gave the permission to Indian manufacturer to build it, is now at the lowest possible prices available to anybody. And then you do the discectomy, you pack the place with biologic, and then you put the cage in. Now, what you need to know from this moment when we start the surgery to the place, to the time that the cage is placed, it literally in average take us about 7 to 10 minutes. So in 7 to 10 minutes, you have done the interbody part. And that enables you to be efficient and you don't cut the corners. That's the point. Now, let's talk about few more things. Yes, you do need double CR. And I was talking about that because we are publishing our paper. There are a few papers we are about to publish. We already published our paper about how much radiation do you get. Go read about that. By proper technique after the learning curve, for somebody who does like 400 of these cases a year, your radiation exposure is like an interventional radiologist at 1/3 of the value that the European organization say it is the maximum. We are at 1/3 of that. But there should be a lot of effort to even make it better. That's not good enough. Additionally, what I need you to understand, the serum you're using today, they're not serum from 1980s. You have intensifier, they use like 1/200 to 1/300 amount of radiation. As a matter of fact, in the United States, the rule is if you are 6 feet away from the source, 6 feet is 2 meters, actually less. You do not need the apron. You do not need the lead apron. So, and this is what their recommendation is. So we are not using the same machine that used to produce a lot of radiation, but still we have to be conscious about it. No question. The actual technique, I think, is beyond just a presentation here. With Dr. Kailash and Dr. Varun, my good friend in India, we have created this different level of fellowship, which is one is complete fellowship, 1 to 2 years, 1 to 3 months short fellowship for experienced spine surgeon, and even for people who have done lots of minimal invasive, 1 to 2 weeks observation. Those techniques need to be taught in person. We mark, and the advantage is here by having AP and lateral at the same time, it's really add to your efficiency beyond what you're used to. And can we do discectomy? Absolutely. And I'm not going to show you, this is all available, by the way, on YouTube. Just go to YouTube, put OLLIF, double L, because this is not OLIF ATP, and then, or my name, you will get lots of videos and so on. And we will as well share that along the side of our society. But what I can tell you, just get involved, add this to your toolkit, and I'm happy to answer few questions in the remaining time. But join our society. We have fellowship. We have a lots of very motivated people to teach you the technique, and add this to your toolkit. Do not stop doing all the other good thing you are doing, but add this to your toolkit, because all of a sudden you can help a lots of additional patient. Other things are not an option. Okay, so I'm going to open the floor for questions.
Okay, thank you very much, Prof. Hamad Abbasi, for your great presentation and for giving me the chance to organize the special conference.
Well, I'm sorry. The question is about our organized conference, because we actually just came from India with our good colleagues, Dr. Kailash, Dr. Varun. We had the hand-on cadaver lab and conference in Bareilly. I'm proud to say that hopefully in next July, I will be with my good friend, Dr. K.K. Kailash in Chennai. We have additional, so join us, sign up for those conferences. But as well, thank you for your help. This is a fantastic venue. I cannot tell you how much I learned myself today. But as well, we are working on a fellowship program in the United States. It is more work here in the United States because for a real fellowship, you have to have UCMLE, CFMG, and so on. But that is why we have collaborated with our great partners in India to make it available to everybody. As well, what I'm really proud of, the hardware is available. Dr. Tara, I know you're from, and I think another doctor is from Syria and Iraq. We have created the Iraq chapter, and just recently, the first Transcamin Olive was performed in Iraq, but somebody who come to Bareilly for a conference. I think the knowledge is spreading, but as well your ability. And this is what I guarantee you. You don't need $1 million machine to do the surgery. The resources you need to do the surgery is available to no matter where you are. And as a matter of fact, I am happy our friend from the Palestine was there. We know what hardship they are going to go through. Dr. Anjem and Dr. Alti, please connect me back. I want, as my organization, donate a whole set to good doctors there to be able to do that. I think it's on all of us to help. And the best way I can help you is that you can to make that sustainable thing that our colleagues now in India can produce everything for you at the cost that if it's available, if it's affordable in India, it will be affordable anywhere else. So I'm really proud of our cooperation with our Indian colleagues and so on. Now, join our society. We have a WhatsApp. I put it in the description. Please join there, and we will connect you to. Please, Dr. Kailash, please go ahead.
I think it's important that I recognize and I come public that we started our Transcamin through Professor Habasi's visit to our institution in Chennai. So we are indebted to him for teaching us and showing us a technique with a double C arm. And we've already finished about 65 or 66 cases so far. And touch wood, no problem so far. So that's one thing which is there. And thank you, Professor Abbasi, for visiting our center and then putting our guys through this. So much so now most of the guys don't allow me to operate. They do the Transcamin by themselves. That's the thing. And the next thing is, as Professor Abbasi mentioned, I, as president of the Minimally Invasive Spine Society of India, take this opportunity to welcome all of you to our meeting in my own hometown, Chennai, in India, in July, to do the annual Minimally Invasive Spine Society meeting, along with the PASMIS and the Chennai Orthopedic Science Society. So all of you are welcome. And I would put my mail on the group chat, and feel free to connect with me. And all of you are quite welcome to visit us and enjoy the hospitality of Chennai. Thank you, Professor Abbasi, again for taking us to a new route. And I can tell you 30 years of experience, and I learned the new trick today. Well, thanks.
And so did I. I think that's what makes you, Professor Kailash, really special, that you and I are with people that we don't never stop learning. And that's what I can advise to all you younger people. But you have help. I love to see a lot of young faces here, and lots of female doctors. You're the future, okay? But you don't have to fight the fight that Dr. Kailash and I had in our time, because we want to be helpful to you to take you to the next step. Connect to us. Dr. Anjem has been a great resource. Dr. Altir is a great resource. They can connect you on my side to Amanda and somebody on our side that give you the resources. Please send us your emails. We give you a certificate. And on Dr. Kailash is putting as well his email there. When you come to Chennai, and please do so, we are happy to create just a lab and a talk to your group of people from Middle East, because I think Middle East has been neglected for a long time, whereas our best are in Europe and USA and helping other people, but our heart is back home. We want to help. So that is why we created the Avicenna Society, Iraq chapter, Gulf chapter, Iran chapter. But I think when we are there, I would like to actually have as well additional meeting just for you guys. What do you guys need to move forward? And we want to make it easy for you. So, Dr. Alti, I really appreciate this fantastic meeting you have put together. We will connect offline. Please make sure that you put as well as your, I see Dr. Kailash email, and I put my email at the beginning. Dr. Farha has put his email. Please copy that right away. Get connected to us. The least you get is a certificate of this attendance to this meeting. But we have a lot more to offer to you to bring it to our people. And I call them not your people, I call them our people. They need help and we can help, okay? Thank you very much for all of you joining this conference.
Thank you, sir. I just want to add, it's a great presentation and great initiative from the Middle East, all the doctors. And Dr. Hamid Abbasi will be soon in Dubai in WFNS for a live cadaver workshop. You are welcome to join. And another workshop will be just after the WFNS. It will be organized by Dr. Shiraj Munshi and also Dr. Hamid Abbasi. So feel free to connect with me and I will definitely help you how much it is possible to get into the training and certification. Thank you very much.
Okay, thank you very much. You all have a great day. Bye-bye.